Afternoon, everybody. Uh, on behalf of IAGES, I welcome you all to this masterclass on thoracoscopic back surgery. This is a field which has been in a nascent stage. There are lots of things that can be done by the VATS procedure, but unfortunately, the general surgeons are unaware of most of the things that can be done. This course will introduce the general surgeons to VATS, and we have got a big array of famous thoracic surgeons from all over the world, and they will enlighten us. About master classes, we have had a lot of master classes starting from plain gallbladder surgeries, complications. We had endoscopic, and we had surprises in laparoscopy, and all of them had been a very successful program. And this will be another one which I hope lots of general surgeons will benefit out of it. For the first speaker, I would invite Dr. Anjali Patil to start the procedure. Dr. Anjali Patil.
Hello. Hello. 1 minute ago. Can you see me?
Yes, we can see you. We can see you.
And my screen?
No, not your screen. Your screen has not come in.
I don't know why it's gone off now.
You have to share your screen.
Yeah, but
there's a green button at the bottom which says share
yes,
screen.
yes.
Click on that.
Yes, sorry about that. That screen, I don't know, it was sharing, it's not getting shared now.
In the meantime, Dr. Patel, in the meantime, I would invite Dr. Raman Goel, our president, to say a few words. And in the meantime, you start sort it out. Raman, would you please come in?
Thank you, Sainda. I thought you have forgotten the president.
No, I didn't. No. How can you forget the president?
Thanks for remembering me.
How can you forget the president?
So thank you so much. Thanks to all the faculty who have joined. I am really, so happy to see you all. It's a rare situation for IAGES to organize a program. This program was in process for almost 2 years. My predecessor, Dr. Saindev Das Gupta, when he was the president last year, had planned to organize this program. And for some one or the other logistical reasons, it got pushed down to this year. And then the lockdown happened. So I'm glad that we are able to do it. And I'm more happy that for the program itself, that because now a larger number of participants can participate. When you have an on-site program like this, I believe only very hardcore thoracoscopy interested surgeons would attend. But now this virtual program has a wide reach. We have academic collaborations with the Society of Bangladesh, Society of Pakistan, Society of Maldives, and they are also able to participate in this program. So this reaches beyond the borders of India, and these 4 surgeons from these 4 nations are able to participate in this program. And that is the strength of a digital world. As far as thoracic surgery being done by, or thoracoscopy being done by general surgeons, I think it's nothing new. And for me, it has an emotional cord. My father was a chest physician who completed his MBBS in 48 from Agra Medical College. And he was sent by government of India those days to Switzerland for training in chest surgery, because the tuberculosis was so rampant those days, and there were no trained chest surgeons in India. And he came back, and for 25 years, as a physician, he was doing chest surgeries. till the time the cardiac surgeries and cardiac surgeons started and thoracic surgery became more of a specialty. So I think for general surgeons and especially those with laparoscopic skills, it's not going to be a very difficult proposition or difficult thing to learn. And it improves the scope of work for us general surgeons, and more so in peripheral cities and towns. So I think Dr. Anjali and Dr. Jayashree had been working really hard to organize this thoracoscopy program, and Dr. Arun Prasad, who has been the backbone of these programs, have been trying to push it. And ultimately, Dr. Saindev, who is the academic chairman of this IAGES this year, finalized this masterclass. So I welcome you all the participants, and I invite Dr. Anjali Patil. We can all see her presentation is ready. To please go ahead. My sincere request to all the speakers, please stick to time because we want more time to participants for their question answers after their presentation. Thank you so much. Dr. Anjali Patil, please.
Thank you so much, Dr. Goel. And thank you, Dr. Sayandev. And Dr. Jayashree Todkar has not yet joined. I thank her too. This is basically going to be an applied anatomy for the general surgeons who want to do thoracoscopic surgery. So we will be going right to the basics, but we must understand that when we compare open versus the thoracoscopic surgery, the anatomy also differs because we have to see it from the perspective of thoracoscopic surgery and not from the perspective of from the perspective of the open surgery. So when we will discuss this anatomy in terms of surface markings, which will be common as to open as well as laparoscopic, thoracoscopic, then the anatomy of the axis, that is more about what you are not going to injure. Then as we move inside, we go to the pleural space, both the hemithoraxes and a little bit on special considerations for the lungs. So surface markings, just to revise them, the sternal angle is at the level of the second costal cartilage, is where we are counting all the ribs. That's where there is the bifurcation of trachea, and that also divides the superior mediastinum from the anterior, middle and posterior divisions of the mediastinum, and it also marks the upper border of the fibrous pericardium. The other surface markings are mainly the ribs, which are very important. Rib counting is important so that you get your ports correctly and you get your incisions correctly. So you have the true ribs, which are the first 7 or 8 ribs, and then the false ribs that are from the vertebral column to the costochondral junctions, and then the last 2 ribs are the floating ribs. The lines that are important are the mid-clavicular line, the anterior, mid and the posterior axillary lines, and you also mark the scapula when in the normal position with the arm adducted, as well as when it gets abducted, it moves, the tip of the scapula moves up a couple of spaces, so it will come down to 6th or 7th intercostal space then. Posteriorly, you have the auscultatory triangle, which is just medial to the scapula and below the trapezius, which is sometimes used as a port by some of the thoracic surgeons. The difference between the abdominal and the thoracic cavities is mainly that the thorax is rigid as opposed to the abdomen, which is expansile. So any changes in pressure, especially if you are using a closed system, would result in the mediastinal shift. So in case you're using any CO2 insufflation, which if you're doing a mini thoracotomy, you would not be using that. But otherwise, in a closed system, you have to understand the mediastinal shifts and keep the CO2 pressures at a very minimal. Plus, in the thorax, you have movements of the lung expansion, the major vascular structures, the beating of the heart, and also the friction of structures over each other. So when you are applying the clips, this is important that especially the metal clips can come off because of this movement at a later stage. So it has to be applied carefully. In thoracoscopic surgery, you're dealing with extremely fragile structures, namely the lungs, the membranous trachea, which are likely to have air leaks if you are not careful, and some of the vessels which are extremely delicate. we go down to the anatomy of the axis, because that is the first thing you are going to have to do when you have to enter the thorax. What in the anatomy part, you must understand the vascular bundle is supposed to be just below the rib above in the groove there, but especially in the older age and a lot of patients, sometimes it might be sagging, it might come to the middle of the space. So whatever you do, you have to avoid injuring this. So your entry should be careful. Otherwise, you will have trickling of blood and the camera in the camera and in the field. And plus, even if you've gone in carefully, later on, if you have too much of friction due to movement of your ports or instruments and the fulcrum effect on the ribs, you could still end up injuring them and having bleeding at a later time. When you are entering, the pleura could be adherent and can result in lung injury. The third thing that when you look at the anatomy of axis is the diaphragm, which when you are on the lower intercostal spaces, you could directly enter into the diaphragm. So you must be careful out there. And directly into the diaphragm could also enter into the abdominal cavity. The next layer that comes is the pleura. Pleura might be having various pathologies like adhesions, lesions, collections. And in India, you have a typical Indian scenario. That is the tubercular adhesions, which make it extremely difficult to access the different structures, and also it results in a lot of many times. What we have to understand is that when we want to access the pleural cavity, we have to allow the lung to collapse. So that is you have to wait for the anesthetist gives you a good collapse of the lung by either by waiting or by suctioning in the endotracheal tube. Use of suction, when you're using suction into this pleural cavity, you could land up in inflating the lung at the same time, especially if you are in a closed system. If you have a mini thoracotomy, that is not a problem. But if it is a closed system, you will realize the moment you use a very powerful suction, the lung will expand. So you might require a little bit of CO2 in those cases. In the open anatomy, everything is open like a book. Of course, even then, for an open thoracic surgery, access is still difficult, but it is even more so because in thoracoscopic surgery, because you see when you go in, this is the kind of picture you see. At the port, you would see just the lung out there. When you go in, you just see the lungs there. And when you go in, you just see the lungs, and you have to understand the anatomy in your head before you know where you want to go and what you want to do. So knowledge of the thoracoscopic anatomy as well as general handling and utmost patience is the key to success. Thus, which is the direction from which you are viewing it. You could be viewing from a lateral position, you could be viewing from a prone position. So the right side and the left side would differ in the anatomy. So if you are viewing it from the bottom part, or your camera port is from the upper part, so your angulation of the camera would also affect the vision and the structures that you see. So when you go in, so you need to kind of have a mental picture. What are you going to, so when we talk about the right thorax anatomy, you have to have a mental picture about where is your lung going to be. Once you lift the lung anteriorly, that is upwards, what are the structures you're going to see? It is mainly on the right side, it is dominated by the azygous vein. So you have the azygous vein that forms a prominent part. Some of the structures are common to both the right and the left. That is, you will see the rib structures, you will see the intercostal spaces, you will see the sympathetic nerves, you will see the pericardium, and you will see the internal mammary artery. So all these are common to both the right and the left, and of course the diaphragm. So this is going to be these are going to be the common structures on the right and the left side, and which are easy to identify. But on the right side, what you would see is mainly the azygous vein. Once you have defined the azygous vein, you look for the superior vena cava. The nerves that are important is the phrenic nerve that runs onto the pericardium, anterior to which will be the thymus. In the upper part, just behind this would be behind the superior vena cava, you have the trachea, the esophagus. As you come lower down, you have the hilum of the lung just below the azygous vein. And below the hilum of the lung, you have the esophagus, and again the aorta and the vertebral bodies. The sympathetic chain would be running on the vertebral body. So this is the anatomy the way you see it there on the right side. So now when you go in with the scope, you will first identify the superior vena cava and the azygous vein out here. And then when you look at the ribs, you will see the sympathetic chain just above it. So this is the region that you are seeing out here. Just behind the superior vena cava, you will see the trachea, the esophagus, and the important nerve here will be the vagus nerve, and here will be the phrenic nerve. The phrenic nerve is a very important landmark. As you have seen it up here, it comes just medial to the root of the lung. So it is very important to safeguard the phrenic nerve when you're going to the root of the lung. Plus, you must understand in the upper, just above the fibrous pericardium, you will see the thymus gland in the upper pericardium, in the upper mediastinum. So, azygous vein, just in the supraazygous part, that is cranial to the azygous vein, you have the esophagus and the trachea. When you dissect in this region, you have to be very careful because this is the area where you are going to have the vagal nerve and the recurrent laryngeal nerve. As you come to the infraazygous part, that is caudal to the azygous, you will see this, the structures here. Here, this is a CA esophagus, so you are seeing a large esophagus with a mass there. So you have the esophagus, just behind it is the aorta and then the vertebra. The right lung has been lifted up. As you go more caudally, you have the inferior pulmonary ligament, which you would have to cut to reach up to the hiatus here, which is where the esophagus is continuing caudally. So this is your azygous, the aorta, and above that will be the esophagus in this area. So when you dissect the esophagus away from the aorta, taking all the lymph nodes, you will have the direct branches of the aorta coming to the esophagus, which will have to be clipped. A very prominent structure on the esophagus is a vagus. So especially if you have a very friable esophagus, it is a good idea to hold a vagus, which is quite a tough structure. So this is now we are seeing from the lower ports, we are looking upwards. So this now you have lifted up the pulmonary ligament, inferior pulmonary ligament is the right lower lobe, and you can see the aorta coming down here. And here the diaphragm and the hiatus will be in this area. What we want to see is the thoracic duct, which is going to be in somewhere around this region. So when you have to ligate the thoracic duct, that is where you are going to look for it. Coming up again, now we are coming to the azygous. As I told you, the hilum is related very close to the azygous. So if you have lifted the lung up and you're looking at it posteriorly, what happens is the right main bronchus is seen to be going downwards. The right main bronchus is being seen going upwards, and the left main bronchus will be going downwards because you're visualizing them from the posterior side. So that's the right main bronchus, the left main bronchus, and the carina. And this is the azygous. And this is where you are going to find the carinal nodes. And this is the esophagus down here. As you dissect behind the azygous, that is where you will find the bronchial arteries, which when you are dissecting the azygous, you need to be careful not to injure them. Otherwise, then it is better to clip them, which are the branches coming directly from the aorta. So as you see the aorta up, as it goes up, the aorta would be going, you would be going to this is the arch of aorta, that is the trachea. So as you know that the left recurrent laryngeal nerve will be coming from this side. So when this is the membranous part, the posterior part of the trachea that you're visualizing, the right bronchus and the left bronchus, and that is going to be the area of the arch of aorta, which is coming down as a descending aorta. So in this region will be your recurrent laryngeal nerve, where you have to be very careful during your dissection not to injure it. So for the anatomy of the recurrent laryngeal nerve, we go back to the anatomy of the vagus nerve. The left recurrent laryngeal nerve will hook around the arch of the aorta, and the right recurrent laryngeal nerve will be hooking around the right subclavian vessels. And that's where you're going to be careful about your dissection. So both the nerves go into the, finally go to the tracheoesophageal groove. I think when we see the esophageal videos, we will be going more into the details of the right recurrent laryngeal nerve nodes. But the most important thing is that you do the dissection in the region of the vagus and then go on to the right subclavian artery and find the right recurrent laryngeal nerve there and take off the nodes. So this is the anatomy in more details. So this is the vagus. When you hook the vagus laterally, you can see the right recurrent nerve going up and hooking up in below the subclavian artery. Now we come to the left hemithorax. Left hemithorax is dominated by the arch of the aorta. So once you realize where the arch of the aorta is, you can define where the hilum of the lung is going to be there, just below the arch. And what is more important is that the structure just below the arch of the aorta is the left pulmonary artery, and this is the aorticopulmonary window here. The nerves that you have to note is the phrenic nerve that goes on to the pericardium, the vagus nerve that comes here, and then it gives off the branch here, the left recurrent laryngeal nerve, which hooks around the arch of aorta and the ligamentum arteriosum that is here. The other structures are common, as in the on the right side is the diaphragm, the intercostal spaces, the ribs, the sympathetic chain, and here on this side you see the subclavian vessels. That is the branches of the arch of aorta, subclavian vessel, the left common carotid artery. So now here, when you look at the apex of the lung, near the apex of the thorax, this is the left subclavian artery. You will have the common carotid artery, and then this is going to be the phrenic nerve that goes onto the phrenic nerve that is going onto the pericardium. And here is the aortic arch. Again, these are the great vessels coming from the aortic arch, and this is the AP window nodes. And this is the root of the left lung. So just lateral to the phrenic nerve again here. And this is where you will have the pulmonary artery. As you come lower down the phrenic nerve, you come to the lower part of the hilum. Here will be the inferior pulmonary ligament. This is the pericardium, inferior pulmonary ligament. And if you divide that inferior pulmonary ligament, you will come to the inferior pulmonary vein. So you can see the relations here. The pulmonary artery here, the superior pulmonary vein, and the inferior pulmonary vein. Then we come to the mediastinum. Mediastinum, that is mainly the thymus. So from the left, when you visualize it from the right side, this is the right phrenic, and you can see the you come from the right side to the thymus. Similarly, from the left side, you see the left phrenic nerve, and then you come to the thymus. This is the aortic arch, the phrenic nerve going on to the pericardium, and then above it the thymus. And in this area above, you see the anterior thoracic wall with the mammary vessels there. And this is the left subclavian artery. So here you should, this is the left brachiocephalic vein, where the vein that goes there, that is the main one that you're going to take, as well as the vessels are quite small here. These are the internal thoracic vessels. We go a little into the lung anatomy now. This is a revision of your open lung anatomy. Basically, on the right side, you have got 3 lobes. On the left side, there are 2 lobes. There are 2 fissures on the right side. That is the oblique fissure and the horizontal fissure, which divides it into superior, middle, and inferior lobe on the right side. Whereas there is only a an oblique fissure, that is the major fissure on the left side, which divides it into the superior and the inferior lobe. These fissures are quite underdeveloped or undeveloped in some patients, and in that case, access to the hilar structures is going to be difficult, and it is important to know the anatomy so that you can go on with your lung resections. So when you look at the lobes of the lung, on the right side, the superior lobe consists of the apical, posterior and anterior segments. The middle lobe consists of the lateral and the medial segments, and the inferior lobe consists of the superior or dorsal segment and the 4 basal segments. On the left side, this apical and posterior combine to form the apico-posterior and the anterior, and the superior and the inferior lingular. These are the parts of the superior lobe, and the inferior lobe consists of the anteromedial basal segment plus 2 basal segments and a superior segment. So in total, you have more segments on the right side and less segments on the left side. So let's start with some of the anatomical features of the right lung. So when you look at the hilum of the lung, here is the azygos, which is your point of definition, and the phrenic nerve, which is another point of definition. Just below the azygos, you can see this is the right main bronchus, is the superior pulmonary vein, the pulmonary artery, and in front of it is the superior pulmonary vein. And low down, when you go from below, open the inferior pulmonary ligament, you come to the inferior pulmonary vein. So when you have to access to the hilum of the lung, the basic thing is that you have to go close to the azygos vein and do your dissection when you want to do it posteriorly and anteriorly near the phrenic. Now,
We've got another 2 minutes.
Okay. So I think this all we will be going into the we go to the superior pulmonary vein, which is just anterior to the pulmonary artery, and it lies into the anterior to the bronchus, and then the inferior pulmonary vein is as I've explained before. I think this anatomy we will be seeing more in details when we do the lobectomies. But what we need to understand is the fissures, the division of the fissures. So when you have to go to the right oblique fissure, you have to go between the middle pulmonary artery and the basilar segment of the lower pulmonary artery. And when you are going to the upper fissure, you have to go between the recurrent vein that goes to the posterior segment of the upper lobe and the dorsal segment of the lower pulmonary artery. And the middle, just medial to the middle pulmonary artery, will be the horizontal fissure. And these are the areas that are going to be important for your dissection. So this is how it is going to look when you are doing your dissection. So here you can see the posterior ascending branch of the upper pulmonary artery. These are the dorsal branches. This is the dorsal branch of the lower pulmonary artery, and these are the basal branches. And this is the middle lobe artery. Contents of the AP, when we come to the left side now, as I've explained the AP window, we have to understand the contents are the left recurrent laryngeal nerve, the left vagus nerve, the ligamentum arteriosum, and the lymph nodes here. I think we don't go into the details of all this. The left hilum anatomy you see is related to the arch of the aorta. You have the aorticopulmonary window, the left pulmonary artery, and the superior pulmonary vein. The inferior pulmonary vein will be near the inferior pulmonary ligament.
Dr. Patil, your time is over.
Yes, okay, thank you. Conclusion, it is a complex, but the thoracoscopic anatomy is complex, but its knowledge is essential to perform VATS successfully and to avoid complications. Thank you.
Thank you, Dr. Patil. We will go into questions later. We'll straight away go to the next topic. Next topic is OT setup and equipment. This will be by Dr. Ali Zamir Khan, who is from UK. He practices in London. Dr. Ali Zamir Khan, please come in.
Chairman, sir, ladies and gentlemen, thank you very much for inviting me to speak on this prestigious forum. I hope you can see my slides. Can somebody just confirm that you can see the slides?
We can see your slide. We
Excellent.
can see your slide.
So whenever we talk of thoracic surgery, we think about this big cut on the chest wall, cutting through muscles, spreading the ribs and getting into the chest. About 15, we have all trained through sternotomies and thoracotomies as cardiothoracic surgeons. But about 15 years ago or 16 years ago, we started doing the program of minimally invasive chest wall surgery, which is video-assisted thoracoscopic surgery, reducing the cuts to tiny cuts, not cutting the muscle, just splitting them, and certainly not putting in a retractor to spread the ribs. And all of this helped to cut down the trauma to the chest wall and helped us to do exactly the same surgery that we were doing with open techniques by using the camera and the keyhole. So we started off with 3-port VATS, and with time, different surgeons developed better techniques, and we went down to 2 ports. And then nowadays the forte is a single port VATS, which is also called as uniportal VATS. And of course, the progress from there on was onto robotic surgery. And then now the new toy in town is the single port robot. So really, I was asked to talk about the theater setup and discuss how should a general surgeon working in a tertiary or a smaller city, how does he start doing VATS? So if you are lucky enough to be in a big hospital which has got 2 towers in your theater, that's great. But most of us would probably have just a single tower. And so I'll show you how you set up your theater to perform video-assisted thoracoscopic surgery, even in the smallest of centers. If you are going to be buying a VATS equipment, then I would suggest that the vision is very important, and you must go for a HD 3-chip camera. A 3-chip camera handles the red RGB, red, green, and blue on 3 separate chips, and so the vision is much more sharper. Of course, technology has moved on, and nowadays we are in the world of wireless thoracoscopes, and we are using this sort of a small portable camera which you can put into your bag and take it to the next hospital if you're operating in multiple units. Also, the light source has gone portable, so instead of having the whole tower, you can have this small LED light source which gives you about 50,000 hours of light. And the beauty of it is that this camera can wirelessly connect to any screen or can connect to any handheld device. Monitors are very important. Please do not buy an HD camera and use a simple ST monitor, because the vision is highly dependent on the quality of the monitor. So please make sure that you invest in a very good monitor. You cannot buy a Mercedes and put in cheap tires. The monitor should be equally good. In the old days, all of us did laparoscopy with xenon light sources, but nowadays the gold standard is an LED light source, because this is a cool light source. Xenon is a hot light source, and most importantly, the electricity usage with this is very low, and the bulb lasts you for more than 50,000 hours. And as I showed you, there is also a portable LED light source which is available. In thoracic surgery, the use of CO2 is very limited. We use CO2 only in thymic surgery or in pediatric thoracic surgery. The chest wall is rigid, and the moment you make your incision and create the pneumothorax, actually the lung drops away and the whole surgery can be done without using CO2. So in our clinical practice, we don't use CO2 as a routine, except for thymic surgery, where the CO2 dissects ahead of you in the mediastinum and helps you to perform your surgery. The important thing that you need to invest is a recording device. It's absolutely mandatory. The way to learn VATS is you must record all your operations, and you must physically edit these operations in the evening so that you can learn from your mistakes and you can become a better surgeon next time. There are many, many personal recording devices available, right from a DVD recorder all the way to a hard disk, HD hard disk drive. So any one of this is available, but the one that we now use is the smart contact lens. And the smart contact lens is something that you put it into your eye, And when you blink your eye, automatically the recording starts. And when you blink your eye, the recording stops. So the beauty of this is that this connects directly by Wi-Fi in the whole theater to a hard disk, and the hard disk can be changed. You can put in 1 terabyte, almost up to 8 terabytes now. And so you can store all your recordings. It's very, very important to record all your operations, because that is the real learning in VATS. There is availability of 3D endoscopes in the market, and they do give you a good depth of perception. But having used robotics, I feel that the 3D and visualization with robotics is far superior to 3D endoscopes. But then there are a lot of people who are using 3D endoscopes, and it's very good, and you can use it if you have the availability to do it. The next question that comes is, where does the surgeon stand? Where is the assistant? Where is the monitor? So there are 2 positions in VATS. The moment the patient is lateral, the surgeon can be in front of the patient, which is called as the anterior approach. And actually 98% of the people around the world do their surgeries in VATS by standing in front of the patient. Whether it's the left side or the right side, it doesn't matter. You stand in front of the patient and access the patient from the front. The advantage of the anterior approach is that you get to the hilum straight away. And so you are in a better position to control it. And the other way, old people like me still do it through the posterior approach, because we trained in the posterior approach. And the advantage of the posterior approach is that the vision is exactly that you get in an open surgery. And the second thing is, if you ever have a bleed in a posterior approach, it takes you literally seconds to get into the chest and control your bleeding. So there are pros and cons to either. This is how an anterior approach is done. You can have 2 ports, you can have 3 ports, and nowadays the fashion is single port. Most people actually around the world are increasingly doing most of their surgeries by making a single 3 to 5 centimeter incision, and the camera and instruments go in through the same thing. And Diego Gonzalez Ribas has popularized this technique, and it has got great advantages for the patient. So if you've got 2 cameras, then if you've got 2 monitors, then your assistant goes opposite, you stand in front, and your scrub nurse comes next to you. So you get more maneuverability. The problem is when you have a single monitor, then all 3 have to come on the same side, but the trolley can go to the opposite side, and that sort of gives you some space to maneuver your movements. If you're doing this as uniportal, then both the surgeon and the assistant are on the same side, because there is no space for the assistant to lean over from the opposite side. The other approach is a posterior approach. Again, you can have a posterior approach dual screen, where the surgeon is on one side, the monitor, the assistant and the nurse is on the opposite side. Or you can have a single screen where all 3 come back on the same side and the monitor goes to the opposite side. It completely depends on what is available in your theater. The Japanese have a technique called as upside down monitor, because in VATS, the vision is a mirror image. When you move your hand to the right, the tip of the instrument moves to the left. And when you move your hand to the left, the tip of the instrument moves to the right. Hence, your brain takes a little more time to get hand-eye coordination. So the Japanese turn the monitor upside down. And so the moment you turn the monitor upside down, it is actually a true intuitive movement. So if you move your hand to the right, the tip moves to the right. And if you move your hand to the left, the tip moves to the left. But it takes some time for your brain to get used to this sort of technique, this upside down monitor technique. But you've got to sort of learn and do whichever way you do. Now, positioning in VATS is very, very, very important. 98% of surgeries are done with the patient lateral. About 2% of surgeries, i.e. thymic surgeries or mediastinal tumors, are done with the patient supine. And esophagus can be done with prone, with Pulnivelu's technique to do prone esophagectomy. I personally am going to show you the posterior approach positioning. So for me, the view should be the same as thoracotomy. The ischial tuberosity should be as low as possible so that the camera can move 180 degrees across the chest and not hit the ischial tuberosity. And the intercostal spaces should be wide open so that you do not damage the intercostal neurovascular bundle. My patient is put lateral always to the edge of the table towards me so that I don't have to lean over and hurt my back. I use a table with 2 breaks. I will keep the patient in such a way that the thoracotomy line lies on the first break and the hip lies on the second break. And I'll start off first by doing a head low. When you do a head low, the intercostal spaces start to open up. But the problem with doing just the head low is that the legs hang down. So the next step is to reverse Tenderloin bend so that the shoulder comes up, the ischial tuberosity goes down, and then the third movement is a leg up. So once you do a head low, reverse Tenderloin and leg up, your three positions are achieved. The shoulder is higher than the ischial tuberosity, the intercostal spaces are wide open, and if you stand at the back of the patient, the view is same as you would get with an open thoracotomy. This is my position, this is a patient. And in the UK, I use bean bags to fix the patient to the table. In India, when I operated in smaller centers or in rural cities, I would use this elastoplast to secure the patient to the table. The key thing is that the patient should not move during the operation. If it's a female patient, because hips are wide, always put an additional soft bolster to lift up the chest, and that puts the hips down so that your camera can move well. Always remember to pad all pressure points because you can get nerve injuries. So ulnar nerve, median nerve, always take care of all pressure points. Always put a soft padding in the axilla below so that you do not get brachial plexus injuries on the opposite side. Always isolate the lung before you go to scrub your hands because it takes about 15 to 20 minutes for the lung to go down. And if you start making an incision immediately after isolation, chances are you will hurt the lung and injure the lung. And that will cause bleeding and your vision will be upset. This is a thymectomy position. You can put the hands on the side or you can put it down below or you can put it on the top. I would not advise putting on the top because sometimes the brachial plexus can get pulled and you might end up with injury to the brachial plexus. Is a worrisome position because if you're not careful, if the hand goes more than 90 degrees, then the brachial plexus will be injured. These are the sort of incisions we make for thymectomies, and we'll talk about it. Whenever you do a lobectomy, I do not put any ports in the 3 centimeters lateral to the vertebral spine because that's a very narrow intercostal space. I draw my thoracotomy line and I draw the tip of the scapula. The tip of the scapula always corresponds with the 5th intercostal space above the 6th rib. And that is the landmark that is used because once you have draped it, it's very difficult to count the ribs. So you always look for the tip of the scapula. And I draw a thoracotomy line and I take away the middle of the thoracotomy line. So my anterior incision is here, my posterior incision is here, and my camera incision is tip of the thoracotomy of the scapula a little anteriorly. I always start with the anterior incision first. I don't go low because I do not want to injure the diaphragm. I will always give preemptive analgesia. I learned this from my general surgery colleagues. And I always aspirate back the lignocaine to make sure that I'm in the correct space. Having done that, I'll make my incision. I usually start with a 10 or usually an 11 or a 12 millimeter incision. And this is the most important step. Particularly in India, it is very, very important because the lungs are stuck. And when lungs are stuck, the one thing that you don't want to do is put in a port straight away. So always put in a finger and dissect around the lung before you put in a port. If this is the only point you take away today, I'll be a happy bunny. Because the number of times people have injured lungs by pushing in a sharp trocar is unimaginable. And then once you have done that, you can use a wound retractor to put it away. But when you're operating in a small place, all I do is put 4 stitches on the 4 corners. That saves you money and saves you using a wound protector. And the 4 corners and the 4 sides keeps the wound open. The moment the wound is open and the pleura is open, a pneumothorax is created and the lung collapses away. So you do not need to use a port, a hard port. The only place where you use a port is where the camera goes in because you want to just protect the intercostal nerve. So these are the 3 incisions, 1, 2, and 3. And this is where the camera has gone. The camera always goes in the lowermost position. And then this becomes your right hand, this becomes your left hand. If you're doing this uniportal, then the whole incision will just come here and all instruments and camera will go through the same port. And that is a technique that's been developed now. I do not use CO2. I only use it for thymectomy. And I just use one 11 mm port only for the camera. The beauty of the chest wall is that the rigidity keeps the ports open and you do not need ports because ports can themselves damage the intercostal nerve and you can get post-operative neuralgia. So this is very important. Cameras, I would use a 30-degree scope. Always learn with a 30-degree scope. Start with a 10 mm, and if it's a pediatric or a younger kid, then you can use 5 or 3 mm. But the worry is that if you bend the camera on the intercostal space, unlike the abdomen, here there are 2 ribs, then you might damage the camera. So a lot of new people may end up damaging 5 mm camera. So start with a 10 mm camera, okay? And I use a 30 degrees all the time. From the word go, learn 30 degrees, and your hand-eye coordination will become 30 degrees. Endochameleon is great, but it is very difficult in the chest, because the moment somebody turns it, very quickly it goes from 30 to 120 degrees, and you don't realize it. Why the hell your hand-eye coordination has gone off? So only very, very experienced people should use endochameleon. Endochameleon works well also in uniportal surgery, where you don't have too much maneuverability of the camera. But in a standard operation, 30 degrees is good enough. Instruments, I would not advise you to use laparoscopic instruments, because the abdomen is different as compared to the chest. This right angle bend is not good for the chest or for your neck or for your back. We've done studies on this, and we found that when you're operating on the chest, you need straight instruments. You do not need that right angle bend. And we use just an open thoracotomy set, albeit we have some long instruments in there. So my standard instrument for a lobectomy would be a peanut dissector on an 18-inch Roberts. I would use a swab on a stick. Very important. This actually saves lives, because when you bleed, all you have to do is push the swab on a stick and put pressure. So this should always be there. And then we have these cheap instruments made in the Indian. We have got these made in the local workshop, and we make these available for very, very cheap. These are dual hinge. There are 2 hinges. So this lies in the chest wall, and it opens up in the front, and the back opens up. So you do not damage the intercostal nerve. So these are available. If you buy a Scanlon set, each instrument is about 1.5 lakhs. But the whole set of 10 instruments with this sort of thing, you can buy for 50 to 60,000. So there are a lot of these new instruments which we developed specifically for the Indian market to help young surgeons in smaller cities to do VATS surgery. Do not forget, always put specimens into bags, because if you do not put specimens into bags, you will end up with port site metastases. Very, very bad thing to happen to the patient. So do not, you can use simple bags. This is just a urinary bag with a purse string on it. And in India, it is pretty cheap to do that. And you can just get the specimen out. Single drain in the chest, and next morning, the drain is removed if there is no air leak. The fluid that comes out is not a worry. We are not worried about the amount of fluid that comes out. We even take out a 300-400 ml. It's not an issue. The important thing is anything that you do by VATS, you must know how to do by open surgery. Please do not attempt to do VATS what you cannot do open, because when things go wrong, the patient's life is saved only by open surgery. And so very, very, very important. There are 4 stages to learning VATS. The first one is you put in your drain site at the start of your thoracotomy. Put the thoracotomy and put the drain site. Put in a VATS camera, and most of the time look down and operate, and for 5 or 10 minutes look up at the camera and operate. And the second advantage is the VATS camera brings the light with it, so the vision in an open case becomes much better. Then you make it into a smaller mini thoracotomy, start doing some basic VATS procedures, and then learn to do advanced VATS procedures. Conversion is never a failure of VATS. This is my last slide. Thank you very much. Conversion is never a failure of VATS. If you're ever worried, please convert. Please convert, because the bottom line is you need a live patient. So please do not be a hero. Just convert to open thoracotomy. Thank you very much for your time and attention.
Thank you, Dr. Ali. It's an excellent talk, amazing talk. Just one question from my side. The mirror image you talked about, can you explain that? Why is it a mirror image?
Yeah, because the way the optics are set up in a VATS, the optical system within a VATS happens in such a way that when you operate in a chest, the fulcrum of movement is the intercostal space. That's one. And when you move your hand down, the tip of the instrument moves up. That is the normal optics of a VATS camera. In robotics, it's completely opposite. Robotics, if you move your hand down, the tip of the instrument moves down. It is already inbuilt into the system to give you a true image. Whereas in VATS, it is always a mirror image. It's the optic. If you look at a camera, a digital camera, actually, when you edit a digital photo onto a software, you will realize that it is what is right is left and what is left is right. And that is the way the optics are set up. It's a principle of physics that is used in VATS. Whereas robotics uses a different principle where the image is inverted. And so you get a more intuitive movement with robotics. And so your brain takes a lot of time to get used to it. That is why it's difficult to learn VATS. And it's the same with laparoscopy as well, sir.
Thank you very much. Now, we move on to the next topic. This is anesthesia and positioning for the surgeon and iatrogenic injury management. This will be taken by Dr. Jignesh Gandhi, who is from Mumbai. Jignesh, over to you.
Yes, sir. Yes, sir. So excellent talk by my previous two speakers. And the reason I chose up this topic was, as I'll go through the slides, I'll let you know, I am a GI, laparoscopy, and a robotic surgeon, but I have a keen interest in doing a lot of non-lung thoracic work at our setup. I have no conflicts of interest, but let me tell you at the outset that I'm not an anesthetist, but I am a husband to a very pretty anesthetist, and that's where I think probably some of my talk messages would come from. So white surgeon and thoracoscopy. Thoracoscopic cases are always very challenging, and sharing is caring. This is one area where you share the airway with the anesthetist in the thoracoscopic cases. So it is very, very crucial. Dr. Ali earlier mentioned that the moment he puts in his ports, the lung is down. But let me tell you the reality that when you start off with the program, your anesthetists are also not very keen, and even the surgeons are not very clear with what they need to understand about. There are challenges because there is lack of universal training in thoracoscopy. Professor Dr. Raman Goel was just discussing about that earlier when we started off with the meeting. The lung compliance is variable because in India, and also I would suggest same abroad, that you have a lot of patients who will be smoker, there'll be early fibrosis. Tuberculosis is our main disease in India. So we come across a lot of cases where we don't expect anything, and the moment we go in, it's absolutely a frozen lung. And help and compliment from the anesthesia colleagues. So I think it's a teamwork where you and your anesthetist, you work together, and that's where I was stimulated to learn more and more about, the single lung anesthesia as we're going to talk today. And the position of the patient can always change the position of the tube, and I think it is so crucial. Sometimes it has happened that we have placed the left tube into the main bronchus, and then the position is changed, and suddenly everything changes there because it has not been fixed properly. There is some technical issues, and that's where we face a lot of problems. So if you see, for the surgeons to understand how it works, by and large, it is always preferred that the surgeon or the anesthetist prefer the left-sided double lumen tube. The reason I will cite that later, because the thing is that most of the times when you put in a left-sided double lumen tube, you have a good control on the right and the left lung both. But when you put in on the right-sided tube, you need this additional opening, which I will show you now. So this is how it is. The left-sided double lumen tube is always preferred, and it is a blue connection, which you can see here. So the blue is for bronchus, so it just goes into the left side. The right-sided, it just stops short here, and then it will ventilate the right lung. That is how you make out on the table. So this is how a left-sided double lumen tube is actually placed when it is inside in the right position. But sometimes what happens is by mistake, the patient moves and this tube flips from this side onto the right side. The problem with this, what occurs is that you are doing a right-sided surgery. You have worked on to collapsing to the right side, but now suddenly your right-sided, the tube has flipped up on this side. This part of the lung doesn't get ventilated properly, and then there are issues, and this can lead into a lot of chaos. So it's always better that the surgeon, if you're starting a thoracoscopy work, start with a left-sided double lumen tube. Discuss this with your anesthesia colleagues so that you are better and safe. So this is the area which gets not ventilated if you're using it on the left side and it accidentally turns around. So there is a difference between the left and the right side. So how do you identify? The right side always will have an additional opening here. And you saw earlier that opening is because the right apical lobe needs a good amount of ventilation. So this is how a surgeon should know that what kind of tube is used, because you need to assist and help your anesthetist all the time when you're doing these kind of cases. So this is how it works. So this is the left-sided double lumen tube put into the patient. Now it's very important that when you're collapsing the right lung, if you want to do a right lung surgery, you have to apply the clamp here. A lot of times, what happens is that people don't understand when even the anesthetist is new, they were to clamp and accidentally they put in a clamp here, but they forget that when you put a clamp here, this vent from where the air is going to come out and collapse your right lung gets affected. So always remember the clamp has to be put more proximally from where it is coming from the ventilator side and not here, because that can affect your lung collapse. And if your lung collapse is not right, you will be struggling inside. So the right lung collapse is only possible when you clamp it more proximally at this level here. This is what is done, which is not the right way to do it. This is absolutely wrong. So blocking the venting also happens here because of the wrong technique, and then you will not get an adequate collapse when you want it. Additional collapse, because sometimes it does happen, as I told you, that when you're starting off with thoracoscopy, you do not get the right amount of collapse which you want. So you need an additional collapse. What you should do is we apply a suction here. So this is something which I shared with my anesthetists when we were starting off with thoracoscopy cases, and they really appreciated that, and they were very happy that I could help them out because I had read about it earlier. So you can put in a suction here, which should be a low pressure suction, and suddenly you will find that your right lung completely collapses, and then you get a very nice, comfortable feel. Patient positioning, this has been put in a lot of times. Now, what happens is for a surgeon like me who is graduating from a GI surgery to a thoracoscopic surgery, I have an abdominal cavity. I can put in 5 liters of carbon dioxide. The moment I put 5 liters of carbon dioxide, I get a nice distension. So I get the whole thing to play. But what happens in thorax? It is as rigid as a rock. In the thoracic cavity, even if I'm going to put 10 liters of CO2 or absolutely nothing, I'm just going to get the same thing. So what happens in thoracoscopic surgery is the surgeon actually works around changing the position of the patient to his advantage. So this is one surgery where it's going to be so important that since you have a rigid cavity, changing the position is what is going to help you. So as you can see here, for a thoracoscopic thymectomy, this would be how I'll be putting my port position. The idea is to put the arms, everything aside. Each surgeon has his own positioning because he would like to put it according to his ergonomics. This is for the resection of the lung. Now, mind you, it is very, very important to strap the lungs, break the table. So the surgeon himself, before he does his first case, he has to look into all these aspects, because if you do not know the maneuverability of your table, you can sometimes land up into a lot of problems. For thoracic sympathectomy, you have to always make the patient sit up like this. So these are small little things. So when I tell my team that this is what we are going to do, we discuss right from the positioning of the patient. It's very important that each member in the team, right from the anesthetist to your first and second assistant, knows exactly what you're going to do. Your OT technicians need to understand what position you're going to give, because together only you can do a good teamwork. Or if you are going to do a surgery here where you need a closed axilla versus an open axilla. So a simple lithotomy attachment like this. Sometimes people tell me I do not have a complicated, a big hi-fi table. I just tell them that you put up a lithotomy attachment here. It will open up your axilla and it will make your life so easy. So sometimes in Indian scenario, we have to do this Indian jugaad, what we call, try to find out the gadgets from our own table and try to get our own positioning properly. Or for a prone position, as Dr. Palanivellu has mentioned, I do all my esophagus through the prone position. Some people do it through a lateral, semi-lateral position. This is how you can achieve getting the patient at the edge of the table is very, very crucial, because most of the time you don't want your hand banging against that area and giving you the trouble. So you can see here in this one of these pictures, look how the patient has been draped and fixed up so well, because you have to sometimes tilt the patient almost to this angle. And you need to look today in the era of medical legal, we need to look at all these cushioning points, because we do not want the patient to have any diathermy related injuries or any injuries related to any pressure source. So this all things are very, very crucial before you actually start your thoracoscopic surgeries. So let me now come to my case. This was a young lady who had symptoms of GERD and hyperacidity. She had gone to a center where she underwent an upper GI-scopy with a local spray. Still in India, we have a lot of cases where we do it under topical spray. And look what happened. I think it was probably the learning curve for the person who was doing the endoscopy. She had a very uncomfortable experience at the end of the scopy, and she had severe neck pain after the procedure. This is what she told me when she came to our setup. And she was discharged to home after the endoscopy. But after going home, she started developing fever and pain during the swallowing. So when she came into us and visit our place, we saw in clinical examination, she had a lot of neck tenderness on the right side. We did a CT scan which showed a collection on the right lower neck region, tracking down into the chest with some air pockets. So we probably felt that there's some kind of a micro perforation happened there because of the struggle while putting in the scope, patient not swallowing properly, and there could be a forceful entry in that area which must have caused this. She had a very high white cell count and she had a septic look. The diagnosis was made of a proximal esophageal perforation, and I was called in to plan for a thoracoscopy because partly the abscess was in the neck and the remaining part of it was going into the chest. So, so this was a positioning which we had planned in that case. We had given it a prone position because for the right-sided procedures, I always give a prone position. I'm very, very comfortable. Now our anesthesia team is used to using the left-sided double lumen tube as I showed you earlier. We collapse the right lung very, very well. So putting in the 3 ports, as rightly mentioned by all the previous speakers, taking all the precautions, then you go in. And now with more and more cases, we get a good lung collapse and very, very comfortably. So if you see this is a video. In perforation of the cervical esophagus, there are conservative approach. But when you have a large amount of collection there, straight away you have to go for a thoracoscopic surgery. So this is the area where the patient had a probable perforation. And because of this, we planned that we should go ahead with a prone position and then put in our ports. So typically I had using the 3-port technique with the triangulation in the 5th, 7th, and the 9th space. The moment I entered inside, I could see some adhesions that you can see here, and there are some pus flakes which are seen in the apex on the right side. So there are these few adhesions which are taken down with a combination of harmonic. Since these were our initial ventures while doing this, so we thought that harmonic is a good tool. So you can do that, and slowly the lung is taken out of the field. She had one more adhesion here. So as I told you, in India, one needs to be very, very careful about tuberculosis because sometimes the past history of tuberculosis in the child can leave ahead some amount of fibrosis and you can have trouble. Slowly, then the lung is taken off. And being a GI surgeon, I use this liver retractor and I push this lung gently down. It really adds to me having that advantage. So a lot of times, you know, the experience of your GI surgery helps you there. You can see that boginess over that in that area. Then we went in and then I opened up in that area where I could see, and you can see nice flow of pus, which is coming in from that area. The part of the sample was collected for culture. And then you can see the suction is put into that. You open up the pleura there and now you can see the pus flakes. So you identify that area very, very comfortably. Once you have done that, you go ahead and widen that opening because you need a good drainage. It is a principle of any abscess anywhere in the body that it has to have a good wide drainage. So what was done was we went in subsequently, sucked out all that area. You can see the pus flakes there. Mind you, sometimes if the patients have a very small perforation somewhere, it is very difficult because you saw this patient manifested almost after 3-4 days. But look at the view with the 30-degree. And because we are used to doing a lot of fundoplications, my assistants are very comfortable in showing me that space up into the neck. So you can go ahead. I removed that part of the pleura because I wanted a free and open drainage. And then I gave it a betadine wash, as you can see in here, cleaned up the cavity completely. So remove all the pus flakes in that area. And then put in an ICD drain in that place. A 28-French drain is placed in that area. It's very difficult, I can tell you, to identify that pinpoint perforation. But if you have given a good lavage, and then this patient was put on a nasojejunal tube at the time of surgery, and then we desufflate the lung after a good wash under vision. So you can see that the lung has been deflated gradually, and then you achieve that. And with this, what happens is that that area gets sealed off. This lady on the post-operative course, the thoracic drain was kept for 1 week. She had a good lung expansion on the chest X-ray subsequently. She responded very well to the broad spectrum antibiotics and sent home on day 7 with the removal of the drain. And her primary issues of GERD were then later managed with the medical management. I thank you all for your attention. And I'm always available on my YouTube or my email or on WhatsApp for any consultation anytime, for any work or any advice, and we can always discuss as a team about any case thoracoscopically. Thank you all for your kind attention, and I'll be happy to answer the questions at the end. Thank you.
Thank you, Jignesh, for a wonderful lecture. It was very good teaching lecture. It's very good. It's excellent. We'll take up questions. Whatever questions are, please, I would ask everybody to put it in the chat box, which can be answered by Dr. Jayashree Todkar and yourself later. Jayashree, are you there?
Thank you, sir. Thank you.
Yes, I am here.
Please take over.
Good evening to everybody. I'm so sorry for some problems in the network. Very well done, all 3 faculties in the beginning. We go to the next session, that is get started. The first lecture will be by Dr. Narendra Agarwal, Diagnostic Thoracoscopy, and he will cover unexplained effusions, lymphadenopathies, fever, biopsy techniques, and many other things. Over to Dr. Agarwal. Thank you very much.
Thank you, everybody, with an excellent session, first session, which enlightened us on the major topic of how to set up thoracoscopic program, along with how to go ahead with anesthesia, positionings, and instrumentation. So my case presentation or my presentation would be much easier for everybody to understand because it has covered 50% of what my presentation meant. So, I mean, I'll start with a very basic presentation of diagnostic thoracoscopy. This is a target population or patients with all the doctors who have just started thoracoscopy with a good knowledge of intervention in thoracic, and they love to do thoracotomies, and they want to go ahead with a thoracoscopic program. So what is diagnostic thoracoscopy? I hope I am, can we go on the next slide? Yeah, so exploration of the thoracic cavity for diagnostic purpose using thoracoscope is thoracoscopy. And why do we do have this? This purely thoracoscopy, why we have a diagnostic word, so we only include in the diagnostic indications. And when these cases are including when biochemistry patients referred for biochemistry, cytology, bacteriology, and they all turn out to be negative, or they are not a good diagnosis with the needle biopsy of the pleura. So the diagnostic efficacy in these cases is more than 90% in the recurrent and unexplained effusion. In the cases of thickened pleura, lung parenchyma, and nodules, staging and biopsy of mediastinal lymph nodes, and staging procedures also helps in determination of disease and many other possible prognosis in lung cancer and management of mesothelioma. So these patients are generally referred from all the specialties like pulmonology, internal medicine, critical care, oncology, immunology, and nephrology. So it's very important for us to, as general surgeons, to develop our skills in thoracoscopy and the basic case we should pick up so that we get maximum referrals and our scope of practice as a general surgeon who is venturing into thoracoscopy increases. And we can actually have a lot of references and win. So what symptoms these patients are referred to you? Mostly patients are generally asymptomatic, but they come with certain patients are coming up with the pleural inflammation causing unexplained fever, dyspnea, and non-productive cough, and chest pain, which is due to pleura. So before we take on to thoracoscopy, what maximum things we need to do to proceed with this thoracoscopy program? So we have to understand for all the reasons that why we are going to do thoracoscopy, what we have going to achieve in the thoracoscopy. So to understand, we have to have a good preoperative imaging studies. And we need to discuss with our radiologist friends or colleagues before we take on any case that what is the importance of radiological imaging in our case to proceed. And secondly, anesthesia. So what case, how the patient is going to be comfortable if certain patients are there in the thoracoscopy in diagnostic cases who are not fit for anesthesia. So what alternative we can have? So we call it medical thoracoscopy done by the medical professionals, but actually it is not so easy when we conclude that medical thoracoscopy can be done by pulmonologists. So we have to understand the difficulties in that also. So, and the position. Again, position has been very well discussed by Dr. Khan, so I would be taking it in a very short way. Port placements and instruments. So whatever is being discussed is in reference how a new general surgeon or a general surgeon who has started his practice in thoracoscopy takes over. So understanding radiological imaging is very important again. So in the slide one, which we are seeing a CT scan, we have to understand every CT scan, whether there is an effusion, whether there is a pleural thickening. There is a very once you made a mistake of getting into a case inside without thinking whether there is an effusion or there is a thickening. So you make a big blunder when you enter inside. So planning it out, whether it is an effusion or whether it is a pleural thickening, you can actually solve the problems which you can venture during the beginning of your career in your thoracoscopy. So, and in cases of you have any references from oncology team, or you as an oncosurgeon, if you have any cases like this and you have to take a biopsy, again you have a PET scan imaging, which helps you to understand which site you have to take a biopsy. So PET scan is again very important in the cases of thorax where you are trying to deal with any ruling out malignancies. So ruling out malignancies, it helps you to stage the disease also, and you rule out whether it is a metastatic lesion or not. So that lies a very important role of imaging. So anesthesia, as discussed by previous speakers, which they again explained very well about the double lumen single lung ventilation. So they explained how ventilation helps and what can go wrong during ventilations and during anesthesia. So at the same time, the anesthesia remains the same, but what changes is if the patient is not fit, what we can do if general anesthesia in these patients are not possible. So there are a few other points where we can go at the local anesthesia, where we can inject at the site of port insertion. And the other options are regional, where we go for epidural, high epidural, where the patient is awake, and we can go a certain sedation. So these patients are still awake, and we can perform a general thoracoscopic diagnostic thoracoscopy. Because since diagnostic thoracoscopy goes a simpler procedure, we can actually start with this even in the patient is awake. So we have a very good contribution from anesthetist in our cases. So position, again, as explained by Dr. Khan, I also prefer having a lateral decubitus position. I prefer because if we need any time of the conversion, we can always convert this patient in to thoracotomy at any time. And once we are trained for thoracotomy, so we know how the position and what organs are going to come at what position. So the anatomy is very important to understand in one position at the same time. So, and the flexion of the operating table, which helps in the widen the intercostal, we don't injure the nerve while entering inside. And since it is again for a target population, so okay. So approach, as explained, we have two approaches: anterior and posterior approach. So what we choose is anterior approach or posterior approach. It depends upon the training or which a surgeon prefers to do. I don't have a preferential that you should approach anterior or posterior approach. Again, there were points where 98% people have started doing with the anterior approach, and 2% are using posterior approach. So I don't really go with that fact. I am trained to do both the anterior and posterior approach, and I always prefer any surgeon prefers can choose their approaches. And when so port placements, again, I have what we have decided that we always kept a common port placement for every cases, so that we don't have difficulty in making earlier in when you start your earlier career, you don't have where we have to place ports. So we always choose to have an anterior mid-axillary line, 4th to 7th intercostal space, one anterior port, first thing which we go inside, and that's a 4th to 5th we choose. And looking at the imaging also, we decide whether it is a good position to go inside or not, or we can always choose a 7th intercostal space, and if we find that that is a better space. So we have to always make the incision at the parallel of the intercostal spaces, and using a hemostat or artery forceps, we go dissecting the muscles. We don't pierce it inside, so that if the lung is adhered, we just don't go inside with the force. And that can cause just what we are not planning to do. You will end up in causing a pneumothorax, or probably converting a case which was a very easy case for a beginner becomes a difficult case to open thoracotomy. So when we have come to instruments, yes, that's true that we in thoracic we are using a more curved force instruments, and we are rightly using the Scanlon and other sets of instruments. But in cases where you have just started your practice and you don't want to enter too many instruments, or you are using instruments of which you are more equipped with using a laparoscopic instruments, you can use a grasper, you can use Maryland, and right angle pottery. So these, and the thoracoscope, which I would also prefer 30 degree, because it's much easier to go deep inside to look at the deeper cavity. And if you look at 0 degree, you might just hit the wall. and you might not be so clear what you are looking at, and you might not be able to understand. But 30-degree, then your camera assistant or a person who should be very, very well trained, where he wants to show you and where you are looking at. So diagnostic exploration of the cavity, I don't think so would be take up, because everybody has explained this so very well. Dr. Anjali has explained the anatomy. So still I will take on the right lung apex, where the most important thing to understand. Generally in diagnostic thoracoscopy, you would not see such a clean anatomy, because there's so many adhesions and you just enter. It's a very difficult way, but still what we have to look upon, what vessels are there at the right lung apex, and where we have to target what. So this is not the area where we actually take biopsies, especially pleura. This is the area where very grievous injuries can happen, and more of vessels are there. So we avoid using anterior and apical region for any biopsies. The posterior, right side posterior aspect is a good point where we can see the prominent ribs. This is a good area where we can target our pleural biopsies. So left lung apex also, we have the same thing, that we have a subclavian and arch of aorta. So we should avoid doing biopsies at this region. We should not venture into this point at the beginning. We just try to use easy procedures, easy way. So this is left lung anterior region. So again, left lung posterior, you have a much better vision, and we can actually do, and you can retract lung on the anterior side, and the posterior you can have a good vision. And when your camera is targeting the pathology, you can actually have a good biopsy. So biopsy forceps is very important where you are targeting this. So what type of pathologies you see in the pleura? So generally, most common cases in our country is tubercular. Nevertheless, we have to always think that every case which comes as a pleural effusion, we always take it as a tubercular, but it is not like that. So there are malignant pleural effusions, there are mesothelioma, there are benign recurrent pleural effusions, and other systemic diseases. So how does a tubercular pathology looks like when you go inside and you, I mean, it's just a way to understand it, and you probably the number of cases you do and the number of diagnostics you do, you will come to know what exactly the pathology looks like. So grayish white granulomous parietal diaphragmatic looks like more of a tubercular. At least you should perform at different sites, different pleural biopsy specimens, so that you don't miss out something. You have two different pathologies. You're not dealing with different paths. So at the same time, what we have to do is gene expert culture and histopathology of the specimen. So malignant pathology always involves visceral pleura also. So pleural fluid is cytology is positive in 60 to 70 cases, and gives a marginal benefit on this. So in diagnostic thoracoscopy, it is much higher yield when we do a biopsy for these malignant pleural effusions. And in case if you have done a frozen section, and if you might need, you can do a pleurodiscs at the same sitting. So this is a finding of a mesothelioma, where you look upon there is a lot of thick pleural nodules, pleural hyperemia, and edema, pleural plaques. So how do we do a pleural biopsy? Is most pathologies we choose posterior costal pleura. Safest is parietal pleura, and over the rib, it's easier to understand that you're not there would be no vessels. And unsafe at the what I told you earlier, also apex and anterior parietal pleura. So when we talk about lymphadenopathy, it's not so easy to just go on and venture inside the lymph node biopsies. But definitely, if we are not doing a lobectomy and we have gone into a diagnostic thoracoscopic work, so we have to choose a point where, after looking at the images, where we can choose to do a biopsy of the mediastinal lymph nodes. So when again in the same image, where if you're looking upon this image 4 and this particular point, you can always look upon the triangle where it is surrounded by SVC, azygotes, and heavy arch of azygotes. So in this area, you will find station 4, which is just lateral to the trachea and esophagus. So this area you can actually have a 4R, and you can have, if a patient has lymphadenopathy or unexplained lymph nodes enlargement, So you can have a good biopsy from here. But this is on a clean case where I'm showing you the anatomy. It's not so easy over there. When you go inside, you have to have a lot of additions and dissections at the apex, and you have to take care of that. You can easily delineate the anatomy in this area. So post-operatively, you have to always connect thoracic cavity with the intercostal drainage. We should never avoid, even if we have done a very good case, we think that we have to connect this. Secondly, because you have a pleural effusion, you have to drain the effusion. You can always keep the tube until the lung expands completely without any air leaks. And as explained, that we don't need to worry about effusion if there is 100 ml or 200 ml. But yeah, air leaks has to be monitored. And adequate analgesia is very important for the patient to recover in the post-operative, which helps the patient to avoid atelectasis and do a good incentive spirometry. This is very basic to any thoracic patient. You have to target two things in post-operative. A good surgery does not mean just a good operative time or a good time to recover a patient. Patient when goes home with no pain and a patient's recovery is completely without any complication, there you call it a good surgery. So we have to target on a good chest physiotherapy and incentive spirometry when patient is completely ambulated on the day 1 or day 2. So complications, again, as the beginning of any thoracic work, we have to understand the most important part is the port access, and the maximum injuries are taking place in the trocar injury. Is when we use any wrong trocar. We should not be using a sharp trocar, and understanding the imaging and going very slow and with using a small, a hemostat, using a very slow dissection and going in a very controlled way inside the pleura. So once we reach the pleura, we have to be very sure we can put a finger, and if there is any adhesions, we can always break that adhesions rather than just going blindly and just thinking that, because it's not like abdomen. Abdomen, you have created a pneumothorax, a pneumo abdomen, and you can actually you can easily go inside that, and you can easily get inside the port. No, so but there are also injuries in the abdomen also, but that's a vessel injuries. So bleeding due to lung laceration. So handling of the lungs is very important during the diagnostic thoracoscopy, because there are a lot of adhesions. We might just not realize, but we might, because there are a lot of adhesions, we might not be able to understand where lung is adhered, and then we might just tear off that can bleed quite profusely. So we have to be very gentle with the lung and handle the lung very softly and gently, so that we don't have a lung tear anywhere inside. Anyways, due to lung laceration, there can be air leak, which can leading to prolonged intercostal drainage. So we should not be in a hurry. Even if there is an air leak, we should not be in a hurry to remove the tube and discharge the patient. Rather than you can discharge the patient along with the intercostal tube if there is a mild air leak. That is not a problem. But the other way you should not do that. You just want to remove the tube and send off the patient. No. So, and the other complication which I have done on myself, that's why I am writing this diaphragmatic tear. So when I was doing a diagnostic thoracoscopy, I didn't realize the lower lobe of the lung was completely adhered to the diaphragm, and that's very, very important, where you have to delineate yourself where diaphragm and where the lower lobe is. So that's the point where I made a mistake, and I made a tear in the diaphragm. So if there is a small tear, you can always leave it, a very small tear. But if there is a big tear, you have to, if you're not competent enough to take you can call another surgeon, or if you think you can do it, then you can open it and do the repair. The repair is important. So when I have discussed about the indications, then besides anesthetic contraindications, we have to understand as a beginner, lack of pleural space due to extensive adhesions and previous pleurodesis or surgery can be a contraindication to diagnostic thoracoscopy. And severe coagulopathy, we should avoid doing all these kind of diagnostic work. So as a surgeon, I would suggest understanding the preoperative imaging well, choice of anesthesia, adequate specimen for diagnostics. When in doubt, do frozen section, and never worry if you have to convert it open to give a diagnostics. I have a video which will follow, because I haven't put in this, but I will have a video. Can we have a video? There's a small video of 3 minutes. So again, I have not mentioned about that it's single port or 3-port or 2-port. It doesn't matter. It depend. All these ports depend upon how skilled you become with time. So I don't say that you are doing 3-port, 2-port, single port, whatever your choice, whatever your comfort, what you have to give result, and you have to give result to the team. So the management of the patient can happen. So what we see is here, we have gone inside, we see there is a stock alert presented. The way we are doing is as a base of this is base. We can see the diaphragm. Again, the diaphragm is adhered to the lower lobe. So we can see all the adhesions. So we should not be very excited to break the adhesions. We don't need to break the adhesions. We are here to only do a diagnostic work. So what we have done, we have used a hemostat, and we have used a thoracoscopic biopsy forceps. So same can be used as a laparoscopic instruments also. So in the beginning, if you don't have those kind of instruments, you can always choose to do with the laparoscopic instruments. So it was a very simple procedure with just one single port. We've done it. But to begin with, you will feel very happy when you finish this, and when your physicians or when your colleagues say the diagnosis of the disease has been made and the treatment started. That will just give you 100% satisfaction, whatever you have done. So no surgery is easy, and at the same time, when you compare all the thoracic procedures which are going to be discussed later on the session, you would realize this was one of the easiest procedures. So what we have connected in the same, because it is a single port, and we have done from the anterior, connected to the chest tube. That's it. Thank you.
So thank you very much, Dr. Narendra Agarwal. That was it. Now we move to the next speaker, Dr. Vishwas. Dr. Vishwas is going to talk about thoracoscopic sympathectomy. Are you there, sir? Hello? Hello?
I can't see him, Dr. Jayashree.
Hello?
I can't see him logged in, Dr. Jayashree.
Yeah, I am also not able to see him.
Please move on to the next topic.
So, maybe we move to the next topic. Dr. Amol Bhanushali, are you here?
Yes.
Amol?
Yes, madam. Good evening.
Amol, good evening. So we move to the next topic, that is ears. Okay. We are starting with the session 3, thoracoscopic video lectures about the lung. So our first speaker in this session is going to be Dr. Amol Bhanushali. He is going to talk about acute and chronic empyema, the management, thoracoscopic management. So over to Dr. Bhanushali.
Very good evening. At the outset, I would like to thank Dr. Jayashree Thodkar, Dr. Raman Goel, and team IAGES for giving me this opportunity and inviting me for this talk. So, empyema, or as we all know, has a triphasic etiology. The options for treatment are drainage by intercostal drainage, catheter-based treatments like fibrinolytics, and then surgical, which is VATS or open. When considering what treatment to choose, you have to consider the efficacy of the treatment, that is, the treatment needs to be definitive, and also consider hospital stay, morbidity, and mortality as well. First treatment choice for pleural empyema is a critical determinant of ultimate therapeutic success. Why do I say this? Is because it frequently shows fast progression to chronicity. This was a landmark article in 2007 by Molnar, which told us about phases of empyema, and these are the various treatment options for the various stages of empyema. And this is what we are going to restrict to in this talk, that is VATS and decortication. So when you talk about VATS decortication, what are the points that we have to consider, especially as a general surgeon when you're venturing into a VATS for an empyema, and you have done open decortications. When you're going to start doing VATS, you start thinking about such things like, does it take too long? Is it too difficult? Will I be able to achieve complete evacuation of the empyema cavity? Will I be able to achieve good lung expansion? Will I end up causing too many lung lacerations? Will I end up with an air leak? When would I want to convert to a thoracotomy? Will I require a thoracotomy or right in the beginning, or maybe not? And what complications or what morbidity can I cause to the patient? So let's try and answer these questions, or let's try and think about this in the further slides. There are enough articles in literature talking about VATS versus open thoracotomy, and most of them have shown VATS to be better than open, so much so that now there is a recent article on uniportal thoracoscopic decortication as well. So there's enough literature showing VATS is the way forward. As far as pre-op workup goes, CECT thorax is mandatory prior to taking up any patient for a decortication. Routine pre-op investigations, evaluation of cardiorespiratory reserve. More important in these patients, especially in the tuberculous ones, is nutritional assessment and build-up. Most of them are nutritionally quite poor. Pulmonary rehabilitation prior to surgery, starting them up on breathing exercises and chest physiotherapy even before the surgery, and adequate anti-tuberculous treatment according to a documented drug sensitivity test is mandatory prior to taking up these patients for surgery. So the WHO guidelines say at least 2 months of ATT, 6 weeks to 2 months of ATT for primary TB, and 4 to 6 months for drug-resistant TB. So that's an ideal thing to do prior to taking them up. So this is imaging for empyema. This is a typical X-ray and then a CT scan of the empyema. So few things to point out here are, you have to assess few things. One is the size of the hemithorax. So you can see here that the hemithorax is contracted as compared to the other side. Secondly, the thickness of the pleura. So this is the parietal pleura and this is the visceral pleura. So assess the thickness of the pleura. Assess the site of the empyema. So here you can see that most of the lungs parenchymal surface is covered by empyema fluid. So here you're still okay, but sometimes there is a loculated empyema only on one aspect of the lung. So when you see my video, you will know why I'm talking about this. That your first port entry into this empyema cavity is important, so that you try and not injure the lung. This is a slightly more chronic empyema, larger cavity with a further collapsed lung. So this is how it looks. This is a fibrothorax or a calcified pleura, what you can call, and this is probably the last stage where more often than not you would leave alone these patients unless this particular patient had developed a sinus draining out of this cavity. That is why I had to operate on her. Of course, it ended up in a normal delivery, but otherwise, usually these kind of calcified pleuras you would not really want to operate on. Patient positioning has been discussed earlier. Lateral decapitous flex the table at the thoracotomy line. Port placement, similar to what Dr. Khan described. 3 ports at the anterior and posterior end of the thoracotomy line and the inferior camera port. So this is standard port positioning. You may have to change this or depending upon the site of the empyema cavity, but most of the times you will be able to deal with all empyemas with the standard port positioning. Only thing is, which port to enter through will be the crux of getting into the chest. So you will see that in the videos. So coming to a few videos, this is the initial stage, the fibrinopurulent stage, more of loculated effusion than an empyema, you can also call it. And when you get into the chest, you see these kind of fibrinous adhesions with fluid interspersed within the loculations. So first job is to take out all the fluid and then take out all these fibrinous adhesions. You can use various kind of instruments. You saw me using a laparoscopic grasper. Since I used one 5 port, you can use a combination of laparoscopic and open surgery instruments. You can use only open instruments, whatever you like. But uh, using curved instruments is always beneficial. Here, since I could get away with using only lap instruments, I was doing that. But mainly, it's personal preference. So when you're trying to open up the lung, important things are removing the visceral peel. So the entire visceral peel has to come off. The lung has to be mobilized completely up to the hilum. Only then it is going to nicely expand. Here, since the parietal pleura was not thickened, I have done only a mechanical fluorodesis. In the next video, I'll also show you a better complete decortication. So this is the post-op X-ray on day 1 with a completely expanded lung. The next video is, I'm sorry. Yeah, the next video is yes. So the next video is of an early stage 3 empyema. This is a large loculated right-sided empyema, and this is the preliminary view. So here, this is me getting into the chest through the anterior port, and here it's all stuck. So the key here is to create space for an additional ports. So you start through one port and then start creating space for additional ports by clearing debris. Once you have removed all the debris and you've got 2 ports in, you are more comfortable. The entire debris, fluid, and everything in between the lung and the parietal pleura has to be first cleared off. Then the next step is to start mobilizing the lung. So you can do that with any blunt instrument. You can use, this is a blunt, long sponge holder. You can use a long artery forceps with a peanut or whatever you like. So here I'm doing it with a combination of swab-on stick and the laparoscopic suction. So this is on the pericardial aspect. Usually there are the adhesions to the diaphragm are always more dense. Once the lung is mobilized, next is, if possible, open up the fissures. They help in lung expansion. And finally, this is the decortication of the visceral pleura. So this is of utmost importance. This is the key step in our decortication. Is exactly what we do in open. The entire visceral pleura has to be peeled off the lung surface. This was the puncture in the lung which probably caused this whole thing, and so this is the entire visceral pleura being peeled off. Here the parietal pleura was quite thick, so I have done a complete parietal pleurectomy as well. So as against open in VATS, it's visceral first and then parietal. Since if you do parietal first, it will keep dripping into your field. So this is the expanded X-ray, and that's the end of the procedure. Now this empyema becomes even more chronic, so it's stayed for a longer time, and the pleura gets even thicker. So here, uh, uh, here you can notice the difference that mobilizing the lung is slightly more difficult. So you have to be very careful again here not to injure the lung. These are steps similar to an open decortication. So I'm using the long pair of scissors, and they're trying to do the adhesiolysis. So this is on the diaphragmatic aspect. If you're in the correct plane, you can very well use scissors. You don't require an energy source. This is after the lung mobilized. Now here the visceral peel wouldn't come off so easily. So like in open decortication, I had to get in between the lung and the visceral pleura, get into the plane and do the adhesive. So I'm not showing you the entire video, but this is how basically it is to be done. If it doesn't come off even by doing this, then you can just take crisscross incisions on the visceral pleura and then maybe leave it alone. So again, this is the complete visceral decortication done through the same port positioning as shown earlier. So what are the complications that you can face? Intraoperatively, parenchymal tears, smaller ones are okay, but sometimes you can have slightly larger, longer ones if you are not in the correct plane. So you need to identify them at the end of the procedure by doing an underwater leak test and suture them if required. Bleeding is not that much of a problem, especially if you're in the correct plane and you don't touch the parietal pleura first. If you do parietal first, then bleeding is an issue. It will keep dripping into the field. So do visceral decortication first, and you should not face that much of a problem. I had faced a bleeding problem and conversion for a bleeding in empyema only in one case so far, and that patient had some coagulopathy. So other than that, usually you should not have a bleeding problem. Third is the peel, the visceral peel is too stuck to the lung parenchyma. Now here, I showed you in the video how to we go into the plane in between the lung, the visceral peel and the lung, but sometimes it's difficult to get into this plane. So either just take crisscross incisions on the visceral pleura up to the lung surface. Here the anesthetist helps you. So tell the anesthetist to start inflating the lung, and that is where you will know where you need to take these incisions and where you can take off this visceral peel. And at times, if even that is not possible, then and if you feel that the lung is not expanding, do not hesitate to convert to a mini thoracotomy or a thoracotomy to do a good visceral decortication, because at the end of the day, that is the key in getting a good lung expansion and avoiding further complications. As far as post-op complications are concerned, prolonged air leak is sometimes an issue. You need to keep the intercostal tube for a slightly longer time. And as long as on X-ray you see the lung completely expanded, usually prolonged air leaks don't require a second intervention. You can send the patient home with the tube connected to a flutter bag or or a Heimlich valve, and usually these leaks stop over a period of time. If the lung is not completely expanded in one section of the hemithorax, you might develop a collection. If the patient is asymptomatic and if the collection is small, you can leave it alone as long as it is not infected and the patient is asymptomatic, also as long as the counts are normal and so on. Otherwise, at times you need to aspirate it or go after it, but usually you can leave it alone. Consolidations are a problem, especially if the lung has been collapsed for a very long time or if the patient has got active TB, then you can end up with a consolidation post-op, but again, not very common complication. And incomplete expansion I spoke about. So the steps to achieve complete expansion I've already described, but still sometimes you might end up having an incomplete expansion. If that happens, you have to try things like connecting the ICD to negative suction or things like that. Very rarely you might have to re-intervene for an incomplete expansion. So to conclude, select the right option in the right patient at the right time. If there isn't enough space, create it. So if you remember, as Dr. Khan said, it's important to put in a finger before putting your first port. So put in a finger, try and create space in between the lung and the pleura to put in your first port. Next to the port, you can put in your first instrument and create more space to put your further ports. Visceral decortication is the key, as I mentioned earlier. Get the lung to the chest wall, leave no space behind. That is again a very key point to avoid few further complications. identify surgically treatable empyema early, try and save the lung. We have had cases where empyemas have been neglected and left alone with lung being collapsed for a very, very long time. And you end up having cornified lungs, which are then very, very messy to treat. And VATS is definitely safe, feasible, and effective, even in late stage empyema. That is very, very evident by now. Thank you. Madam, you are muted. You need to unmute yourself.
Hello, Dr. George.
Yeah, hi. Can you see me?
So let's move ahead with your topic now, which is lobectomy and pneumonectomy.
Just a second. Can you see my screen? Not yet.
I request every speaker to please keep on with the timings because we are really running little late, almost half an hour.
Yeah, hi. Let me. I'm going to start off with. I'm supposed to show two videos, which are two upper lobectomy, so I can familiarize everyone who's watching with the anatomy, particularly related to the pulmonary hilum. So I'm going to start off with the upper uniportal left upper lobectomy. So it's a 79-year-old lady. I'm going to play it a little bit faster than normal so that I can finish off a little bit faster. So this is a CT scan run showing, a tiny lesion T1. So this is the position which we take. This you can see is the posterior axillary line, and the incision is between the mid and the posterior axillary line. So I must stop the video and tell you this is absolutely the wrong way to make a uniportal incision. I use a uniportal incision. It's preferable not to use diathermy so that the intercostal nerve is not damaged. So we have switched from this technique. This causes a lot of pain. Should avoid using diathermy while making the port. This is the surgical sleeve which we use to isolate the port from any contamination. There are two companies which provided Alexis and Covidien. You can use whichever one. It gives us adequate space to use the camera and all the other instruments. As you can see, I prefer a uniportal technique. I apologize for the speed with which it's being shown. In a few seconds, I will show you the hilum. This is where we start the dissection in the anterior hilum. You can see the phrenic nerve running across here. Now it's better. The structure, that's a phrenic nerve, and that's a superior pulmonary vein, which you can see. And that's the pulmonary artery, which I was showing over there. This is the pulmonary artery. So the first job in upper lobectomy is to dissect out the superior pulmonary vein. As you can see that with the uniportal view, you can actually see the vessels head on. So this is the superior pulmonary vein, which we are seeing. I'm going to reduce the speed a little bit. It's a little bit confusing. That's the superior pulmonary vein which we looked. Then we go on to the dissection of the left main pulmonary artery by taking off all the structures. So that's the left main pulmonary artery, and you can see the arch of the aorta over here, and this is the left main pulmonary artery. So we continue dissection there, and it's always easier to take off all the lymph nodes first. This makes dissection of the other structures easier. Here you can see me identifying two branches of the pulmonary artery. So because the left upper lobe has 3 segments, you expect 3 branches and 2 branches into the lingular lobe also. Total of 5 branches to the lingular artery, from the PA to be divided. And one of the advantages of using a uniportal technique is that you can see that I'm using a Roberts to dissect. Preferably use vascular staplers because they're much more stable and unlikely to come off. So that's one of the branches being divided. Here again, you can see that I'm taking off the lymph nodes so that it becomes easier to dissect the vessels. always when you use the harmonic, be absolutely sure that the active blade is away from the vessels. Otherwise, you might have a horrendous injury. Again, I'm using an open mixture. Any 9-inch instrument is adequate enough to dissect any of the vessels and for reach. Again, a vascular stapler is used, preferably one with a tip up because it's easier to negotiate across the gap. So that means you have seen 2 vessels divided, 2 of the arteries gone. Now you will see one tiny vessel here. Now the biggest problem in such surgeries is always a tiny vessels because the stapler is too big for them and a tie might actually go off. So use a small clip. Just using an energy source is not good enough, safer to clip. So use the smallest clip possible and clip those. So after dividing the upper 3 branches, we know that there are 2 more branches from the pulmonary artery. Now this is the fissure and that's the interlobar artery. So we are dissecting in between the upper lobe and the lower lobe. And the attempt is to dissect the artery so we can identify the branches to the lingula, which we expect to. So what we are seeing here is the lingular artery. That's the interlobar artery. And we are dissecting anterior to it so that the fissure is divided completely. So at this stage, I switch back because there is nothing else stopping me. And I take the superior pulmonary vein. So this is one of the rare structures which is preferable to loop. So getting the loop across gives you adequate traction and you can bring the stapler into location. So it's important, like I said earlier, to clear the lymph nodes because without taking off the lymph nodes, you might not find enough space to actually go across these structures. You will find that your instrument goes across, but your stapler doesn't go across. And this loop, the superior pulmonary vein on either side are 2 of the structures which actually require a loop for the stapler to go across. Now the stapler is safely across and you can see me firing it and that's the vein separated. Now again, you go back to the fissure. And this, at this point, let me stop it, stop the video. This is the superior pulmonary vein going here. And this is the inferior pulmonary vein going to the lower lobe. So you are going to dissect in between so that the upper lobe is completely separated off from the lower lobe. That's the parenchyma. So that's a dissection on the interlobar artery. So that the upper lobe is completely separated off from the lower lobe. You can do the dissection with the harmonic. Sometimes when the fissure is too not well developed, you can use a stapler, which is the preferred technique so that the vessels are not, so that there is no parenchymal leak. So you can see these small vessels again supplying the upper lobe branches. Again, small one. Don't try energy source alone. Always safer to clip. So you can see that's the lingular artery over there. Again, you can use a simple Roberts. An open instrument is good enough to go across. Now that you have divided all the structures, all the vessels, you can see that's a bronchoscope shining inside. That's the only bronchus. You pass a stapler across. Now it's a key step that once a stapler is passed across, you ask the anesthetist to inflate the lower lobe and make sure that the lower lobe ventilates. Only after confirming ventilation of the remaining lung do we actually divide the stapler. And this is the remaining hilum. And that's a resected bed. And now you continue on to doing the remaining lymph node dissection, which is the posterior hilar. Always when you use a clip, you have to make sure that after the surgery, you don't. So that's a space, the left paratracheal space, which you have reached thoracoscopically. And that's the remaining lymph node dissection. Now I'm going to stop this video here. Oops. And I'm going to show a left SMLND actually. So that is the left paratracheal space. So if you can see, I'm between the pulmonary artery and the arch of the aorta. And from there, I reach the left paratracheal space. And for those of you who ask a question as to how we reach a subcarinal space, sorry, how you reach it is from anterior. So this is the place. So I'll stop the video here. This is the superior pulmonary vein over here. This is the bronchus running in this direction over here. And this is the area which is the subcarinal nodes. So we're doing an anterior approach. And those are the subcarinal nodes which can be seen there. So this is a fairly complex lymph node dissection, and it's initially difficult to retract the heart and the superior pulmonary vein and get there, but we can essentially clear it. So from this, what you're seeing in the bed over here, after removing the lymph nodes, you can see it's almost a complete clearance, is the, sorry, that's the esophagus over there. The pink fibers which you can see are the esophagus. So I'm going to stop this video here, and then I'll show you the it's again a uniportal right upper lobe lesion, right resection. One key step which I forgot to mention in the previous one is that you always free the inferior pulmonary ligament. Just make sure that the lower lobe comes up to fill the space left after the resection of the upper lobe. It also helps you get time so that your rest of your team gets accustomed to the whole surgery and the angles. As usual, when you see operate in India, you'll get adhesions, which are part of the process, and then you do. So again, this is the phrenic nerve, which you can see. This is the azygous vein, and this is the SVC joining it. And you start dissecting it in, which is the hilum. Again, preferred, that's the superior pulmonary vein, upper branch, which has come into view. Again, when you dissect, make sure that the active blade stays away from the vessels. So you can see at this point, this is the uppermost, the first branch of the truncus of the PA coming into view. And that's the lower paratracheal lymph nodes just beneath the azygous. I'm going to increase the speed. I think I'm a little bit behind time. So it's like I kept mentioning earlier, it's easier to take off the lymph nodes first so that you expose all the vessels. So the azygous bed. You can do this entire dissection with a hook cautery also, which is my favorite instrument usually. But when it's uniportal and you have only two hands to operate without an assistant in the field, sometimes it's easier to use a harmonic. So that's a superior pulmonary vein which is being dissected. It's always important to make sure that the branch to the middle lobe is saved. Because if we take the middle lobe vein, then it becomes difficult to salvage the middle lobe. So once you exposed all the vessels, this is the truncus, or the first branch supplying the upper lobe. And this is the superior pulmonary vein, which runs almost in the same direction, which we asked, looping up. So once you've done that, you continue the pleural cuts. That's a bronchus, which you can see over there, over here. This is the bronchus, the right main bronchus. Then you take the posterior cuts. So the lung is completely mobilized. Then you staple off the truncus. Again, vascular tip-up stapler is helpful. Again, like I said, the pulmonary vein is one of the vessels which you need to loop up, because then only it will come up to the desired angle so that the stapler goes in easily. A tip-up stapler again really helps. So those are the two main vessels looped up. Again, the lymph nodes come in, and it's easier to dissect all these lymph nodes first. Makes your life easier when you want to dissect the main bronchus and the remaining vessels, because you expect two more branches to the upper lobe. So those are the lymph nodes going up. And now you can see the upper lobe bronchus there. So this is a fissureless technique in which I have not dissected the fissure, but since I'm sure this is the upper lobe bronchus, I'm clamping it. And like in the previous case, I have decided to ventilate, and the anesthetist has shown me middle lobe getting ventilated, and then I divide it. So that's the interlobar artery coming into view. But I still suspect one more branch to be going to the upper lobe. So that is the branch. That's a posterior ascending artery which supplies the middle lobe. Now, to ensure that's going up to the upper lobe, I dissected the fissure, and this is the fissure and the interlobar PA running in the fissure. Since this patient had reasonably well-developed fissures, you can see that the dissection is easy, and I've reached right across to the posterior pleural space. See, that's the stump of the artery. So in this case, the fissure is not that well done like in the first case. So I use a stapler to divide and separate the upper and the lower lobes. So once that is done, I now know for sure that the lower branch, which you, the lower branch which you see over here is actually segment 6 branch going to the lower lobe, and this one over here is the segment 3 branch. So at this point, I decide I have to take this the upper one, which you can see. So that's the importance of dividing the fissure. Again, I do not divide it without getting a clip. Sorry.
Dr. George, you will have to be a little faster.
Oh, I'm sorry. So I think that's all the vessels taken, and that's the final stapler going in between the middle lobe and the lower lobe, upper lobe. And I guess that's the upper lobectomy specimen coming out. So that's the hilum remaining, all the hilar structures divided. And as explained by all the previous speakers, we use a bag to take out the specimen. Do I have enough time or to do the lymph node dissection, or can I stop here?
No, actually, we don't have time.
Okay, excellent. So I will stop here. Apologies for overstepping my time. Thank you very much.
Thank you very much. I think in the A to Z of thoracoscopy, we will be able to give good justice to all the topics. This being an introductory scene. Now we move to the next speaker, Dr. Bhushan Thobre, who is going to talk upon pneumothorax and bullae. Thank you, Dr. George. Thank you very much.
Thank you very much.
Dr. Thobre, you are there?
Yes.
Please start.
I'm just sharing my screen. Hold on a second. Yes. Yeah. Greetings. Thank you, Dr. Arun Prasad, Dr. Jayashree Torkar, and Dr. Ali Zabir Khan, and all the IAGES team members. Greetings from Medanta Medicity. This talk is dedicated to all teachers who have taught me thoracic surgery since last 10 to 12 years. So I'll be talking about pneumothorax and management of bullae. So everybody knows in a thoracic surgical practice or any general surgical practice, you will come across an emergent situation where a patient will land up in emergency breathless, will have subcutaneous emphysema, his saturations might be dropping, and will be called that you need to put a chest drain immediately. Once in a while, you may be called for this condition, which chest drains is a salvage procedure which saves a person's life immediately from a complication like tension pneumothorax. So you can see these X-rays. There is a pneumothorax. So pneumothorax is defined as abnormal collection of air in pleural cavity. Everybody knows Itard, a student of Lennox, who first coined the term pneumothorax, and Lennox described this picture. There's a pneumothorax. First of all, I'll go with a little bit orientation about classification. It is spontaneous and acquired. In spontaneous, we have primary and secondary. In primary, those who do not have clinical lung disease. So there might be a rupture of subpleural blebs or bullae. And in secondary, there is a pre-existing lung disease, which the lung will be some disease process, bullous lung disease, cystic disease, malignancy, infectious causes, or maybe some connective tissue disorders. And maximum number of causes of pneumothorax, 80 to 80% are traumatic. Then comes the iatrogenic and then the barotrauma. So traumatic are both blunt and penetrating trauma. Both might be road traffic accidents or missile or gunshot injuries. Iatrogenic, we know during any intervention, radiological procedures or bedside pleural aspirations or diagnostic procedures, or after a laparoscopic surgery where diaphragm might have congenital fenestrations. And nowadays, due to COVID situation everywhere in the world, we are getting increased referrals or barotrauma induced pneumothoraxis, that is due to ventilator and due to primary pathology affecting COVID affecting the lungs. So diagnosis of pneumothorax is generally mainly clinical. It is auscultation, clinical examination, and strong suspicion. And then comes the chest X-ray and the CT thorax once the patient is settled. That is what. There are many treatment options for pneumothorax. One small pneumothorax, less than 10%, you can observe. That might be after some needle procedure, something. Needle aspiration, I personally don't advocate, although theoretically they mention small pneumothoraces, you can aspirate them. We recommend is a chest drainage, chest tube insertion, and chest tube size. We generally BTS guidelines and all these guidelines mention about 24 to 20 number chest tubes, but we recommend 28 number chest drainage system connected to underwater seal. Then pleurodesis also comes in the one part of management, as I will go in the video demonstration. Then thoracoscopy, thoracotomy with bullaectomy, and pleurodesis, both either mechanical or chemical, or without pleurectomy. So tension pneumothorax, I would like to mention, it is a dreaded complication. It is due to large air leak. Most of the times it is mainly on ventilator. Diagnosis is always clinical, and immediate decompression via chest tube has to be made. That's one. Chest drain insertion, everybody knows, remains the mainstay treatment in management of pneumothorax. Fifth intercostal space in the triangle of safety and connecting to a underwater seal drain container. So now indications for operative intervention in case of a pneumothorax is persistent air leak, that is greater than 3 to 5 days of failure of lung to fully re-expand in spite of chest drainage and in spite of negative suction applied to the chest drain. Hydropneumothorax or any pneumothorax is getting complicated, recurrent ipsilateral pneumothorax or bilateral spontaneous pneumothorax, or first occurrence of contralateral pneumothorax, or some at-risk professions like pilots or divers, or any person who has history of one-side pneumothorax and has a bulla or CT diagnosed pathology on the other side, which can land up the patient to an emergency, who has a poor access to the medical treatment, we should consider for operative treatment. So you can see there, this was a boy who had a recurrent pneumothorax. He had underwent 2 or 3 times chest drain insertion. When he landed up the third time, we decided to do a thoracoscopy because he had continued air leak, and we can see there was a small bulla lying in the left lower lobe segment 6. Then this is another example of one bulla. So bullae, there are these are focal regions of emphysema with no discernible wall. They are around more than 1 to 2 centimeter diameter, and pulmonary blebs are generally less than 1 or 2 centimeter diameter. Both are subpleural, and a giant bulla is like one that occupies more than third of volume of the hemithorax. So this can be called as a very giant bulla. So some complications if you don't treat bullae, or sometimes very rarely they get complicated by infection in the bulla, and that may lead to empyema. This was one of the case with a long-standing bulla which got infected, and we had to do a decortication, and we found out there is an infected bulla lying inside. So in treatment, do not put chest drain in a silent bulla. Always distinguish what is a pneumothorax and what is a bulla. If you are in doubt, do a CT scan when the patient is stable. That is all. So if pneumothorax, then chest drain placement, allow the lung to expand, do a CT thorax, operative bulla seen. If bulla not seen in pneumothorax and air leak stops, lung fully expands, observe. If recurrent, then operate. So do we need to treat other side as well? Only in certain occupations like pilots and those engaged in diving sports, we need to operate, or those who has poor access to the healthcare facility. So this is a case of 29-year-old young lady with no comorbidities, had recurrent right-sided pneumothorax with chest drain insertions, and landed with us with mild breathlessness on OPD basis. We did a CT scan. We saw multiple bullae and subcutaneous emphysema extending up to the neck. This is the actual view of the CT scan, and this is the coronal view which showed multiple bullae at the apex and some pneumothorax component. So we decided to do a thoracoscopy. We did via uniportal approach. So you can see multiple bullae at the apex. You can grab those bullae. They won't rupture. The walls are very much not very fragile. This thing. And rest of the bullae we had ligated. Even ligation of bulla is mentioned in literature, where there is a famous Japanese study in available online, where they have compared ligation of bulla versus stapling of bulla. That is all. So we are introducing the stapler across the bulla, taking the whole of the is to be taken so that your suture line doesn't give way. You adjust the staples accordingly so that the whole and all the bullae element is within the stapler. Then you should see all the borders of the stapler before firing it. And once you have stapled the bulla, any residual tissue can be cut with scissors, keeping the staple line on the lung side. Then you should ask your anesthetist to inflate the lung. You have to check for any air leaks by adding water into the thorax. That is called the air leak test. If there is no leak in the thorax, then you can move ahead with our next option. That is for pleurodesis. Either you can go mechanical pleurodesis or chemical pleurodesis. Okay. Yeah. So the complications after this surgery are persistent space problems. If you have stapled a lot of apical lung, there will be a space problem. There might be again air leak if you are not checked the whole lung surfaces, all the areas properly. There might be some small bulla which you have not attended it, or your staple line might have given away, or a long-standing pneumothorax, a non-expansion of the lung may be problems. So before attempting any lung surgery for bulla, you should have the knowledge about the staplers and which type of cartridges you should use. These are available all online. You can go to any of those branded available staplers. They have similar
Dr.
color
Tombre?
codings. Yeah.
Again, time's up.
Yeah. Okay. I will try.
Yeah.
So aberration pleurodesis is one of the option for this thing. You can do the aberration pleurodesis by taking a gauze piece and abrading the surface of the pleura to make it rough so that lung adheres to the chest wall. You to make sure that lot of pleura has been abraded, mainly the apexes where the airway tension is very high. It should look like red and it should start bleeding. Blood also acts as a pleurodesis agent. So talc can be used, magnesium silicate slurry. I don't advocate slurry. I advocate powderage by medical thoracoscopy or VATS. For pneumothorax, you can use 2 gram. This should be deferred for old people where you do not expect any other further surgery. For young patients, you reserve pleurectomy or aberration pleurodesis. So this is one video of talc powderage. Sorry, this video is for malignant effusion, but this is an example how you have to do powderage. So you have to create a hailstorm-like appearance in the chest so that all powder particles are spread across evenly along the lung surface and as well as the whole of the pleura, whole of the diaphragm, under surface of the lung and along the hilum and the mediastinal pleura. So that there is no pleural space, so there will be no pneumothoraxes later. So this is a made Indian jugaad of spraying the powder. You can apply CO2 insufflator to this also and spray the talc. So complications of talc are these all: fever, pain, shortness of breath, hemoptysis. There are many complications. So this is our outcome of 3-port VATS. This is uniportal VATS. And I would like to mention about digital thoracic suction devices. We use often after our bullaectomy and pleurectomy surgery. These key help us to keep the lung expanded and adhered for the first 24 to 48 hours, so that recurrent pneumothoraxes after ICD removal chances are very less. So again, the COVID and pneumothorax, the incidence is low. Subcutaneous emphysema more common. Pneumothorax unilateral, bilateral. Very high mortality with these type of patients. Thank you. Stay safe, pray, live long. Thank you.
Thank you very much, Dr. Bhushan. And thank you very much for typically mentioning about the some suction, low suction. Okay, very important for this thoracoscopic surgery. We move to the next session, which is thoracoscopic video lectures, non-lung. Requesting Dr. Sabita to please take over thoracoscopic esophagectomy.
Can you see my screen?
We can see you.
Oh, I'm so sorry. 1 minute. Sharing my screen.
Yes.
Yeah. So good evening, everyone, and thank you, Dr. Jayashree, for organizing this and inviting me. So I will be talking about a thoracoscopic esophagectomy with a 3-field lymphadenectomy. And just to get started, surgery for esophageal cancer involves removal of the diseased esophagus with an adequate margin, maintaining the continuity of the gastrointestinal tract, and making provision for the patient's feeding post-operatively. And since afternoon, we are listening why we are talking about thoracoscopy. So these pictures are self-explanatory, and I don't need to talk more about this. We already know that thoracoscopy has better outcomes when it comes to esophageal cancer surgery. There's decreased pain, decreased blood loss, fewer pulmonary complications, a shorter ICU and hospital stay. It is oncologically equivalent. And now there's level 1 evidence from these 2 randomized controlled trials that there is decreased pulmonary complications also. Coming to the technical details, these are the typical ports that we use for a thoracoscopic esophagectomy when done in the lateral position. So you could choose any of the 3 positions, lateral, semi-prone or prone. It depends on your expertise and your preference. Traditionally, we were taught that the lateral position is the best when dealing with complications because it closely resembles an open surgery. But actually, if you are experienced in open surgery, the position should not make much of a difference. The only caveat being that a prone position is always more difficult for the anesthetist to manage the airway. You can use any number of ports from 4 to 6, and now there are reports of uniportal esophagectomy also coming in. Lung isolation with a bronchial blocker or a double lumen tube is preferred. And you could also utilize capnothorax when your lung isolation or lung collapse is not very great. So please do not rule out capnothorax. It's a useful adjunct in many cases. So coming to the video itself, this is a post-neoadjuvant chemotherapy, bulky lower thoracic esophageal cancer. And as you can see, there were some lung adhesions which we have already released. We start by incising the medial aspect of the mediastinal pleura at the border of the lung, so as to get a clear avascular plane where you will see the pericardium, and also this will give you a good circumferential resection margin. So you could take the lymph nodes along with the esophagus, or you could take them out separately. It is your personal preference and depends on your expertise. So now you can see the glistening pericardium which has come into view as we are lifting off the esophagus. There will be some vessels on the pericardial side also, and these need to be cauterized. And you go on mobilizing till you reach the far end of the pericardium, okay? And at the level of the bronchus, you'll see the vagus as well as a few vessels accompanying it. So the white structure here is the right main bronchus, and there are lymph nodes along that, the subcarinal packet of lymph nodes. Along with the vagus, there'll always be a small blood vessel, so that needs to be cauterized or clipped. Be very careful using energy devices in this area because there's potential of damaging the posterior wall of the bronchus, which we all know is membranous. So slowly you take this vagus and its accompanying vessel off, and it's possible most of the time to see the left main bronchus from the anterior view. It is also equally okay if you start by incising the lateral pericardium, lateral pleura, but usually I prefer to mobilize it anteriorly and then take the lateral cuts. When you take the lateral cuts, you can see the azygous vein running down the thoracic cavity vertically, and below is the descending aorta. So unless your tumor is very bulky or it is very advanced, which is usually not seen nowadays in the era of neoadjuvant therapy, you may sometimes need to take this fibrofatty tissue en bloc with the esophagus, which contains the chyle duct. So you keep mobilizing the lateral pleural cut till you see the pleura of the opposite side. Even if you open the pleura of the opposite side, it's okay. Just be sure that you inform the anesthetist so they have a clue about it and they can remind you to put an ICD on the opposite side also. There will be direct branches coming off from the descending aorta, and these can be cauterized either with a harmonic or a hook, whichever one you prefer, but make sure they're cauterized well. Some branches may also need clipping. Coming to the supraazygous mobilization, you need to open the pleura in the posterior mediastinum. Usually that's safer because anterior is the trachea. You make a U-shaped cut over the azygous, okay, and then you mobilize the esophagus from the posterior aspect of the thorax, where it really tends to dip down in the supraazygous part, and then you take it off from the fascia between the trachea and the esophagus. So one key point which I always tell my residents, in the supraazygous part, whatever you think is the esophagus may actually be the trachea. So be really, really careful over there, and make a good space if you're planning to take the azygous vein. So you can save the azygous vein, but there are certain indications where you will definitely want to take it. One is when you have a bulky middle third tumor. So there may be lymphatics and lymph nodes in this area. So it's better to take the azygous vein when you're dissecting. The second important indication, which is not an absolute indication, is when you're doing a 3-field lymphadenectomy. It just gives you more space if you have taken the azygous vein. And also, if you have a bulky patient who will have a large omentum accompanying the gastric tube that you make, so if the azygous is intact, it may actually constrict the blood vessels. Now, after taking the azygous, I am taking the thoracic duct here. The anatomical landmarks for taking the thoracic duct are the azygous vein, which is running down, and the descending aorta. So whatever fibrofatty tissue you see in between the azygous and the aorta, okay, you just loop it and till you see the wall of the aorta from this side, and take the whole tissue together. If you try and dissect the chyle duct separately, you may actually end up injuring it. You can use metallic clips, but hemlock clips are preferable. And also the chyle duct, taking the chyle duct is a matter of preference. So you may choose to preserve it if you think you have not injured it. This is the area of the right recurrent nerve. So this is the right vagus. You go up the right vagus and you see fibrofatty tissue and lymph nodes towards the apex of the thorax, okay, and that is the subclavian artery pulsating on top. So as we all know, and Dr. Anjali pointed out, the right recurrent will go below the subclavian. We saw it there, a glimpse of the right recurrent nerve. So you take out the fibrofatty tissue there along with the lymph nodes, you clear that, and be careful not to use energy devices, a combination of blunt and sharp dissection. Now coming posterior to the trachea, you retract the trachea gently with a suction or a retractor. You take the esophagus up and you can see the left recurrent nerve which runs on the left posterior border of the trachea. So here, it's coming into view. You can see the nerve with a small blood vessel over it. And it's important to remember not to hold the nerve directly. Use your very vascular forceps or scanlon forceps to hold the perineural tissue, the adventitia around the nerve, but don't hold the nerve directly. And also, lymph nodes are most commonly found in the groove between the nerve and the trachea. So don't look only lateral to the nerve. That's not where most of the lymph nodes will be. The lymph nodes will be in between the trachea and the nerve. And that's how the trachea actually ends up getting devascularized during this three-field lymphadenectomy. So you can see this patient has a lot of lymph nodes, and you are all, literally end up stripping the nerve trying to remove. So be very careful. Don't use energy devices. Blunt dissection and then a few sharp cuts. You may encounter bleeding in this area, but the best thing is just to swab it, give some pressure, and then go back to dissecting. These are small vessels which will typically not bleed a lot, but if you try to cauterize them, you may end up injuring the nerve itself. So this is all the dissection along the left recurrent. I'll go a little fast here because in the interest of time. And now we have come to the aortopulmonary window. So to dissect the aortopulmonary window, what you need to do is retract the left main bronchus. So this suction here is retracting the left main bronchus. And then you open this space up. By retracting the left main bronchus, you can see the arch of aorta pulsations on top. So this space is typically below the arch of aorta, and in the depth is the main pulmonary artery. So you can see these lymph nodes coming up. Again, you will encounter the left recurrent laryngeal nerve here as it hooks around the arch aorta. So careful dissection, least use of energy devices, and carefully dissect out the nodes while preserving the nerve. So again, you may tend to encounter some bleeding, but just give pressure, be patient, and slowly dissect out the nodes. Because even in depth, you have a fragile structure, which is the pulmonary artery, whose adventitia and wall is not as, strong as the arch aorta. So you may actually end up injuring it while you're working in this depth in the aortopulmonary window. So you identify the nerve here, you clear out the lymph nodes, and then you come to the subcarinal area and take out the subcarinal lymph nodes to complete your three-field lymphadenectomy. That is between the two bronchi, if you have not already taken these nodes along with the specimen. So just a small 1-minute video on how we mobilize the stomach for making the gastric conduit. So this is a laparoscopic mobilization. You go along the greater omentum at least 1.5–2 centimeters below the right gastroepiploic artery arcade, because that is the main blood supply to the future conduit. So you keep going along the greater omentum and you mobilize towards the pylorus. You need to mobilize because otherwise your stomach will not reach the neck. Then you take the short gastric vessels which are coming from the splenic artery, and be careful not to injure the spleen here. So then you open the lesser omentum, and once you open this lesser omentum, you'll be able to see the left gastric vessels here. When you're dissecting the left gastric vessels, just take all the lymphatic and fibrofatty tissue upwards towards the specimen, because that will be taken off when you form your gastric conduit. So this is a left gastric vein. The left gastric artery is usually behind. This is clipping the left gastric artery. And once you clip it, I usually don't divide it. I just keep the clips on and do the D2 lymphadenectomy. So when you're doing the D2 lymphadenectomy, just roll the pancreas down like you do in an open lymphadenectomy. You will see the hepatic, common hepatic coming into view, and take all the fibrofatty tissue above the common hepatic. So you just roll down the pancreas, take it off, and then finally you mobilize the hiatus, where you should take care not to cut the diaphragmatic fibers, not to cut the muscle, because this unidentified mistake can actually lead to a post-operative hiatus hernia. So just go along the peritoneum and take your cuts there. Completing the surgery, you mobilize the esophagus in the neck, you loop it, then you will retrieve the specimen, you will form the gastric tube, and then you can do a cervical anastomosis, either Hansen or staple. It completely depends on you. Thank you so much.
Thank you very much, Dr. Savita. You did it in your time. Thanks a lot. Now, actually, we are moving to the next topic, that is thymectomy by Dr. Arun Prasad. I want to tell all the audience and the faculty to please stay logged in, because we are going to take all the questions at the end. So over to Dr. Arun Prasad now.
Thank you. I'll start sharing my screen. Is my screen and audio all right? Can somebody confirm?
We can hear you.
And you can see the screen as well?
Yeah.
Yes.
Okay, fine. So I've got this video to show about thymectomy. And while the video is going on, I will be talking a few words. My job has been made very easy by the fantastic anatomy presentation, which was the first talk of this meeting today. And thank you very much for inviting me to give this talk today. I have also learned a lot from the previous speakers. So without wasting more time, let me move ahead with my video. So when we talk about thoracoscopic thymectomy, first thing is that the patient is in the supine position. The surgeon can either be on the right, which is what I prefer. There are 3 ports which I use for access. The telescopic port in the 5th intercostal space and anterior axillary line, and 2 other ports on either side of that. This is the phrenic nerve, and that is the upper edge of the pericardium, and that is the thymic area. So this is the anatomy that needs to be remembered. You start your surgery at the angle between the nerve and the pericardium, what I call as the pericardio-phrenic angle. So if you could see that angle, I've just pulled up the pleura there, and this is where we should start. So this is a crucial point there. So this is the next point, which is lift the thymus and the fat from the floor. So when you lift it off the floor, you will find this loose areolar tissue. There are small arteries which can either be clipped or coagulated. Arteries are never a problem, and most of the time you can do the entire surgery without the need to clip any artery. Just your harmonic should be enough. However, sometimes you see large arteries like this, and it's always better to clip it. You proceed further till the left lung is visualized on the straight ahead, and the left phrenic nerve is also visualized there. The left thymic vein is clipped and cut. Now, the left thymic vein is the largest vein, largest vascular structure which you are going to face when you are doing a thymectomy surgery. And hence, I feel that the left thymic vein clipping is most crucial. The right one is usually again very small and can be secured with your harmonic. So you've gone to the opposite side, you see the lung there, see the left phrenic nerve, get the left thymic vein, and then start moving back. Sometimes the right thymic vein is also large, so you may need to clip that too. But as I said to you, these two, the thymic arterial supply and the right thymic vein, most cases you should be able to just get it with your harmonic. There are these large fat cells which go along with the thymus gland. They should be removed. In the periphery, sometimes you see small fat cells which are actually subpleural fat, that depending upon the BMI of the patient, it may be a lot, so you don't have to chase that. The specimen is removed inside a specimen bag, and you can see during hemostasis, you should be able to see the bare pericardium there. You can see the phrenic nerve there, the right thymic vein. The arch of aorta should be pulsating, pink, it looks pink and pulsatile. The innominate vein should be bared, and the left thymic vein straight ahead. Then you can see the left-sided pleura and the lung on the opposite side. At the end, any remaining fat which you can see, you can excise easily. You should remove it, especially when you are doing this surgery for myasthenia gravis. If you are doing it for thymoma, then you need not chase the excessive fat. Check for bleeding. So that's the specimen which comes out, and if you place it on the table, it looks like this. These are the port positions. Again, you see the 10 mm and 5 mm ports which we have put. Now, thymectomy these days is also nicely done robotically, and I now prefer robotic thymectomy if whenever possible. So we'll show you a video again. The anatomy and the steps remains the same. However, you can see this video by the thymectomy. Now here, the left shoulder, the robot is going to come. The right arm has to be placed in a lower position so that it does not clash with the robotic arms. So this is the robot which has been wheeled in. This is known as docking of the robot, where the robotic arms are connected to the robotic ports. Instruments are introduced. So as you can see, there are 3 port technique. So there's a harmonic, there's a grasper, and there's a telescope. Now again, you can see the innominate vessels. You can see the ribs, apex of lung, the sympathetic chain. Identify the pericardium there. You identify the phrenic nerve. Go to the pericardiophrenix angle. That's where the thymus lies, and that's where you enter the mediastinum. So this is a thymoma which we are removing. As you can see, that lumpy structure there. Go flush in that loose avascular areolar tissue till you see the arch of aorta, and now you can lift off the arch of aorta there. Going on towards the left side, taking it off the left pleural surface, entering the superior mediastinum, freeing from the innominate vein. Now, freeing from the innominate vein, I feel that we should do from below. Otherwise, there is a risk of entering the innominate vein if you go from above. And as you are freeing, once the entire thymus is freed, you will see the thymic vein there, and that is being clipped. So in this particular case, we did not encounter any large vein on the left side, but we found the vein on the right side. So this is a thymoma which has been excised. Not much blood loss. This is quite an avascular space. Specimen is put into a sterile bag and removed from one of the trocar sites. Many surgeons do it with 4 ports, but I think 3 is enough in most cases. This is another case where we are doing it from the left side, because the thymoma was predominantly on the left side of the patient. Most surgeries, as I said, I'm happy doing it from the right side. This is the upper lobe of the lung, the left subclavian artery. That's our node of the aortopulmonary window. This is the left phrenic nerve, the pericardium. Again, we go into the pericardiophrenix angle. And do this inferior dissection. Then go medially. Finally, the superior dissection. Put it in a bag and remove it. Again, this was a thymoma. So fairly simple surgery if you've got your ports correctly. So there are few tips which I have got for people who are starting to do thymectomy surgery. First one is your port placement is extremely important. Put in the first port, as I showed you, in the fifth intercostal space, anterior axillary line. Once the telescope is inside, plan your other two ports. There is no fixed rule about where the other two ports should be. So put in the telescope, look inside, see how you get the best triangulation. And the target of your triangulation should be the thymic vein or the innominate vein. So with that target, you plan your other two ports and do it in a nice triangulated fashion, following all the basic principles of minimal access surgery. So there should be no clash of instruments. This clash of instruments tip is even more important when we are talking about the robotic procedure. And one way to prevent clash of instruments in the robotic is keep your right hand instrument absolutely as low as possible, just above the diaphragm in the anterior axillary line or so, and keep your left instrument almost in the axilla. So for that, the right arm should be placed in a below the table angulation and place this in the right axilla. Another tip would be that if you put a 12 mm port in the right axilla, third instrument, you can use the same port to take out the specimen with the bag and even enlarge it. And being in the axilla, it hardly leaves any visible scar. Start at the pericardiophrenix angle. That is the most crucial point. And most surgeons who have trained with me call it my angle, and always suggest that remember this angle. If you enter from this angle, the anatomy and the subsequent dissection becomes very easy. Cross over to the left side to show the phrenic nerve. Beware of the thymic vein. The innominate vein dissection should be from below the, not thyroid, thymus. I've written thyroid by mistake. And the innominate vein dissection should be from below. So you lift up the gland with one hand and dissect under it, because if you are dissecting over it, there is always a risk of going into the innominate vein. So to conclude, I would like to say minimal access surgery of thymus is one of the best examples for advantages. So when there are talks about how minimal access surgery has changed the way surgery is practiced over the last 20-30 years, the best example I can give is that of a thymectomy. In fact, the benefits of the thymectomy minimal access surgery is far more than the benefit of even laparoscopic cholecystectomy, which is used as the classic example. So I always give the example of thymectomy and bariatric surgery as the two areas where minimal access surgery has really revolutionized the way surgery is practiced. There is a learning curve, so you should have a mentor with you during the learning curve. You should have adequate thoracotomy skills, or if you are not comfortable with thoracotomy, have a thoracic surgeon to provide you backup whenever required. With that, I would like to end my talk. Thank you very much. Be safe. Use your masks, gloves, sanitizers, social distancing in these pandemic areas. All the best.
Thank you very much, Dr. Arun, for the very nice presentation. And I agree totally with you that thymus is one of the most benefited surgeries as far as minimally invasive technique is concerned, for the patient, for the doctor, for the precision, safety, and the post-operative outcomes also. I remember just one thing to share here. In the SAGES in 2003, I had presented the video of the total thoracoscopic thymectomy for myasthenia gravis, unilateral approach. And that was awarded with the best video presentation, best technique. And I'm very happy to share with you all that it is still in the SAGES Pearls in the library in the name of me and my team. So it's really one of the great pleasures to see thymectomy and do it again and again. Moving to the next speaker, Dr. Shilpa Gandhi. She is going to talk on chylothorax. Shilpa, are you there?
Yes.
Yes, Shilpa.
You see, yeah. I'll just start sharing my screen first. Yeah. Can everybody hear me?
Yes, we can hear you. We can see the screen also.
Yeah, great.
Can you make it full screen?
Yes. Yes.
Nice.
I'm Dr. Shilpa Gandhi, and I'm a thoracic surgeon from India, and I've recently migrated to UK as a clinical fellow in thoracic surgery. I have immense gratitude towards Arun Prasad sir, Jayashree Todkar madam, and entire IAGES team to invite me as a faculty speaker. This meet is very nostalgic because I'm seeing a lot of old faces. I could never imagine coming across Todkar ma'am after a gap of at least a decade. I'm her very, very old student. Probably she may not be even recognizing my face. Okay. So coming to chylothorax, this is one entity which you can clearly describe as the tip of an iceberg. You will see and you know what you see, but there is much more to it as far as management of chylothorax is concerned. It's a huge process, and I will take you to this journey throughout my talk. Beginning to the introduction to the chylothorax is nothing but accumulation of chyle in the pleural space because of the obstruction or injury to the thoracic duct. It's not an exciting complication, even if it is rare, at least 4 to 5% of these patients, but these can be serious, and if not well attended, they can actually be life-threatening. Post-iatrogenic or post-surgical complications are by far the most common etiology, followed by neoplastic and idiopathic. Coming to a brief anatomy of the thoracic duct, it is a tubular structure starting against the L2 body upper vertebra in the abdomen from the cisterna chyli, and then it ascends in the posterior mediastinum. It's just staying anterior to the vertebral body, but on the right side, and it ascends to the aortic hiatus. Then it crosses from the right to the left against the T4 vertebra, where it stays above against the aortic, behind the aortic arch, and left to the esophagus. This is the site of injury mostly in aortic arch surgeries, as well as in some esophagectomy surgeries too. Coming to its termination, and just like its variable course, it has a variable termination also. Ideally, it ends in medial to the scalenus anticus muscle, just deep to the neck, at the jugulo-subclavian angle, staying within the 2 centimeters of this landmark. However, this duct can enter directly into any nearby vein, either independently into internal jugular vein or subclavian vein or any other nearby vein. So you have to be very well versed with the anatomy, its origin, course, as well as termination. Coming to chyle, it's nothing but fat, which is cholesterol predominant, but it also has a lot of T cells and fat soluble vitamins as well as electrolytes. At least 1.5 to 2.5 liters of it is produced per day. The literature shows an extensive list of an etiology of chylothorax. I've just simplified it by dividing into a classification of congenital, which is less common, but they are mostly syndromic in association, post-traumatic or nothing but post-iatrogenic. This is by far the most common segment of etiology, and wherein esophagectomy at least comprises of 1 to 9% of the incidence of these cases, and followed by a post-coronary artery bypass surgery. Then tuberculosis, of course, can lead to any disease entities, including chylothorax, then advanced mediastinal lymph nodes or advanced lung cancers, and then sarcoidosis or amyloidosis can also give rise to chylothorax as a rare presentation. Coming to clinical features of presentation, it will definitely have a prior history if it is post-iatrogenic. These patients are usually, they present after day 7 or day 7 onwards. So it has a very insidious onset, but once it presents, it can have a very rapid accumulation. So depending upon, if it's a low volume, it could be silent, where these patients, they do not require any kind of an intervention. Or if it is high volume symptomatic, then you have to be alert. Coming to laboratory examination, appearance of the fluid in the form of milky white discharge from the chest drainage is the ideal, very characteristic of chylothorax. These, when you do analysis of these fluid, they will show T cell predominant, at least 80% of them, and the count will be more than 1,000 cells. Presence of chylomicrons is actually the most ideal investigation of choice, which is rampantly available in majority of the institutes. Hence, we take as a pleural fluid ratio or the pleural fluid content of triglyceride as well as cholesterol as a diagnostic modality. We also should keep into mind an entity called as pseudo-chylothorax, whereby this ratio will get, or these values will get entirely reversed. Coming to basic imaging, so not mandatory, but yes, many institutes, they do advise doing a lymphangiogram. It could be a CT lymphangiogram or MR lymphangiogram. These are very less invasive, and they will give you the site of leak, the complete anatomical course of the duct, as well as inclusive of the aberrant anomalies associated with the duct. One thing to mention is about the 3D SPECT, wherein you can actually get to some more information about the functional component of the thoracic duct. Coming to straightforward indications of operating these patients. Yes, these patients, if left unattended, they can be very notorious. Nutritional imbalance can happen on prolonged conservative management, which will give rise to loss of fat and fat-soluble vitamins, as well as the T lymphocytes. These patients, they hence can land up in risk of septicemia complications. Then, of course, as mentioned before, post-esophagectomy are the upfront cases for operative repair. And anything above 800 ml per day in the chest drain for consecutive 5 days, you should be alarmed. It should be alarming, and it should be considered as a threshold for operative repair. And of course, failure of maximal medical therapy. Coming to initial approach, like I said before taking the patient for surgery, you must stabilize the general condition by putting the patient on nil by mouth or at least a medium chain triglyceride diet, and then you thereby you observe. Some people do advise, or they give an additional somatostatin analogs infusion, like octreotide infusion, to reduce the production of the chyle. Then at this stage, lymphangiogram should be done so that you get the entire anatomical delineation of the, and as well as the site of the perforation. And this is also the stage wherein, if it is low volume, you can actually directly consider for a thoracic duct embolization. Coming to identification of the leak. So having said that, visualization of the leak is the ideal, but nevertheless very frequently encountered situation. Of course, you will be able to, if you're lucky, you can be able to see a milky white discharge from one particular site in, suppose, the mid or lower thoracic cavity, just at the site of the perforation. However, this is not very ideal, like I said before. So many people, they do give high dose of talc, milk, or high cream through the Ryle's tube just 15 to 20 minutes prior to the surgery. And after that, you are able to see the leakage of this talc through the site of the perforation. In place of talc, some people can incorporate using, it depends upon the availability. If it is available, then dyes can be used like ICG. Of course, like I said before, lymphangogram will definitely clear the picture if it has been done before. Coming to which compartment to address to. So this is the organ or the duct which actually travels 3 compartments from abdomen to thorax to neck. So, but since we are actually the most commonly compartment to be addressed and very, very ideally and easy to address is definitely the transthoracic approach. So when we talk about the VATS ligation or the thoracic ligation, which side to take into account first? Of course, many people think that it could be the one with the chest tube, but ideal and again easy is to address the right-sided thoracic duct. Why? Because it's solitary, it is not duplicated, and it has a much more constant course as against the left-sided. However, in cases of CABGs, any side can have present as a chylothorax. Coming to surgical approach, it could be open, VATS, robotic, depending upon the surgeon expertise, underlying etiology, and the patient demand. Here, however, these kind of cases are actually very easily dealt with thoracoscopic approach. Hence, these usually are in majority of the centers, majority of the thoracic surgeons, they actually deal with it by VATS, plain simple VATS ligation. Again, when we talk about thoracoscopic, we have already discussed in great details about the anterior and posterior approach in all our previous talks. I would be here more stressing in the anterior approach. This is the right-sided VATS anterior approach. These are just pictorial images to make you understand about the port placements. So the basic principle of port placement for thoracic duct ligation is that our target organ and the site of the ligation, it is much below, just above the diaphragm. So you have to, so all the ports, they are as compared to the conventional, they go a little one space below. So for example, we have in this case we did a utility incision much below in the 7th space, but still staying anterior to the anterior axillary line. And secondly, yes, anterior approach. Why? Because the surgeon has to stand anteriorly, because your organ or the target organ is placed much behind, that is in the posterior mediastinum. Coming to the setup doesn't require too much of fancy instruments. Just a 10 millimeter of 30-degree telescope is fair enough, along with your basic VATS instruments and one endoscopic clip applicator. So what we do is we just first divide the inferior pulmonary ligament, retract the lung anteriorly. We identify the posterior mediastinal pleura and divide it. At any case, you have to reach to the esophagus to press the diaphragm. I will explain this in much detail in this video. So this video was a case. This was a case of left-sided chylothorax post-CABG. Which we had seen it in Manipal hospitals last year in 2009. So this case was done by a right-sided VATS anterior approach along with Dr. Prasad. So in this, as I mentioned, the previous ports placements, we had with 3 ports. So here what we are doing is we have already divided inferior pulmonary ligament. Now this is the posterior mediastinal pleura we have identified, and we are trying to divide it. So we were actually very lucky to have a very virgin right-sided pleural cavity, because it was a left-sided chylothorax. And hence the entire anatomy is very clearly identified and the structures are very clean. However, and this may not be the case if it is a right-sided one, and you can actually struggle in finding the esophagus, or you may actually struggle right from the port placement, because you may incur a lot of adhesions. So this is the vagus nerve, and by that I mean that we are very close to the esophagus. Now we are trying to identify the entire esophagus. First we will identify the anterior as well as the posterior border, make a window, or try making a window. You can actually sloop the esophagus at this stage so that it becomes easy for you to retract. One more important step I would suggest, what I would say at this point is, once we have identified the posterior border of the esophagus. Now we are actually, if you see, the diaphragm has been depressed. You are not able to see the diaphragm because it has been depressed completely with a Rampley's or a sponge on a holder. And this is the most important step to identify the thoracic duct, because it is much below. It is just above the diaphragmatic hiatus, you can say. You have to identify or try identifying the duct or the tissues, the fibrofatty tissues, just against the vertebral bodies and staying behind the esophagus. So here we were, since I said before, we were very lucky or fortunate to have a virgin right-sided pleural cavity, and we could see a thoracic duct, and we were in a position to delineate it. So once identified, it's a small, very tiny cord-like structure, but the ideal is always to have a two-side double ligation. Proximal as well as distal. Yes. You may or may not divide it. We just ligated it doubly. I'm sorry. Yeah, so like I said, this was the pictorial image. This is the double ligation site, staying just above the diaphragmatic hiatus. In post-esophagectomy, this step is a routine step whereby you can actually do it as a two-side. So one proximal staying just below the azygous vein and one distally. Having said that, this procedure should always be clubbed with on the site of the chylothorax, it should always be clubbed with a pleurodesis, either mechanical or chemical. So a talc pleurodesis is rampantly or easily available, easy to use and instill. So it should be always done to get maximum results. So you get best results or best successful outcomes in cases of post-iatrogenic cases, at least 90 to 100%. This patient actually had a disappearance of the chyle from the chest drainage right from the day one of surgery. I will have shared one slide extra. This can be of interest to the general surgeons. So this, when in cases of failed VATS ligation or persistent or refractory chylothorax, many people, they do advise going to the transabdominal approach. Now, this is a very familiar area for at least the general surgeons, but however, I would like to highlight some points. You can address directly to the cisterna chyli. For transabdominal approach, however, you need to go absolutely behind the liver by dividing the the coronary ligaments or the attachments of the liver and going absolutely retroid or retrohepatic. There you would be able to identify cisterna chyli. It is the landmark is it is just against the origin of this celiac artery. So some people, they do, in cases of failed or persistent chylothorax or failed VATS ligation, they address as a second procedure in the form of a direct cisterna chyli ligation transabdominally. Only you have to make sure that you do not damage the celiac artery origin. Coming to some alternative therapies, yes, literature have mentioned some alternative therapies in which can be favorable and can give good outcome, even if your previous surgery has failed. Like we can, even if you're not able to find good planes, or if you're not able to do a mass ligation or a duct ligation, you can just do a VATS pleurectomy and come out. Or you could just do a pleurodesis and come out. Yes, if it is a high output chylothorax, you could do a pleurovenous or a pleuroperitoneal shunt by shunting the fluid from pleural cavity into the peritoneal cavity. Then some have also recommended a platelet-rich plasma pleurodesis or blood pleurodesis. It's very easy to do and with excellent outcome. And of course, like I mentioned before, thoracic duct embolization. These, however, for doing thoracic duct embolization, you would definitely need a very, very experienced interventional radiology team. Coming to the management algorithm, like I said before, it's a tip of iceberg. So what you see, you have to really indulge into a process to manage it. first we start with the conservative management in the form of a chest drain insertion and putting the patient on a medium chain triglyceride diet. If it persists still, you would need to put the patient on nil by mouth and start a total parenteral nutrition. At this stage, you can actually think of doing a thoracic duct embolization straightforward. If it stops, it's good. You can remove the chest drain after doing a talc pleurodesis. And you would need to continue with the medium chain triglyceride diet for at least 6 weeks. However, like I mentioned before, if it is a persistent chylothorax, a high output chylothorax, or a rapidly increasing or symptomatic patients for a long duration, then these are the ideal candidates for a VATS ligation with pleurodesis. Coming to the last slide, it will show the schematic flow chart of the candidates to select. High volume chylothorax, failed conservative or idiopathic and congenital chylothorax are straightforward cases for operative repair. Then post-surgical or post-iatrogenic or traumatic are again straightforward cases. And failed surgical ligation or unfit for general anesthesia are cases for you can consider for a thoracic duct embolization. Thank you.
Thank you very much, Dr. Shilpa. That was really one of the nice presentations, and I'm very happy to connect with you again after so many years.
Yes.
Shilpa used to be my resident many years back.
10 years, almost 8 years back. Yes.
So now we are moving to the next session of panel discussion. Before that, Dr. Ishwar Murthy would like to say a few words, and because he has to connect to the next webinar at some other place. Over to Dr. Ishwar Murthy, please.
Jayashree, good evening. You carry on with the panel discussion. I'll do it at the end, no problem. I like to look forward to your lecture before I do a vote of thanks. It will be more appropriate. Thank you.
Thank you very much. Thank you very much. So, Kritika, can you please start with my presentation? For this panel discussion, we are going to invite Dr. John Thanakumar, one of the very senior thoracoscopic surgeons from whom I learned my thoracoscopy maybe in the 90s, and all our faculty present here. I request you, all of you, to please be a part of this panel discussion. The panel is going to be typically discussing about the troubleshooting, the trouble prevention and management of complications of thoracoscopic surgery. So can you start with my presentation, please, Kritika?
Dr. Jay, we do not have your presentation.
I have sent it, no, already.
No, we have not received it.
Oh, okay, no problem. I will start.
Please, can you try it from your end?
Yeah, I will. Okay, I will do it from here. So before we get connected with the presentation, I have received some questions for the panel, for the faculty. I would go ahead with the questions. The first question is about the practice of thoracoscopic surgery in the geriatric patients. I would like to take this question to Dr. Ali Zamir Khan. Are you there, doctor?
I think he mentioned on the chat box earlier that he's going to leave and then he's going to come back again because he had another meeting.
Okay, so no problem. Maybe I would direct this question to Dr. Sabita. Are you there?
Yes, Dr. Jam.
So there is a question. In geriatric patients, what are the specific conditions we will look upon in terms of the risk handling, and what are the indications where would you say that we won't do it in geriatric patients, the old patients?
The thoracoscopic surgery works better for geriatric patients because you avoid a thoracotomy. So for the general workup of the patients, you would use the same criteria that you use for other patients. You would look at the lung function, the PFT as well as the DLCO. You would look at the cardiac function. But these elderly people may also have been smokers for longer periods of time. So you really need to look at your lung windows on your CT scan if there is any fibrosis, any evidence of adhesions. Then you will also look at their comorbidities So a lot of them can be on cardiac medication as well as having pacemakers or undergone previous cardiac procedures. So you need to keep that in mind. And also there may be some people who are on blood thinners. So that also needs to be kept in mind. But all the evidence, there's no level 1 evidence, but there are large systematic reviews and the SEER database, which shows that thoracoscopic surgery actually works better for geriatric patients, and they are able to complete their adjuvant therapy, especially after lung resections. So any geriatric patient definitely consider as a candidate for thoracoscopy.
Thank you very much. I hope the delegates have received their answers. One question is directed to Dr. Arun Prasad. How to look for left phrenic nerve from the right side during thymectomy?
Yes. So when you are crossing over, you will reach the opposite side pleura, and then trying to avoid making a breach into the pleura, you have to start going down inferiorly, and inferiorly you will find a junction. So it's like the end of a room where the floor is the arch of aorta and the mediastinum, and the opposite side where the wall finishes, that's where at that junction you will see the left phrenic nerve. So you need to go for this, especially when you are doing cases of myasthenia gravis in a non-thymoma patient, where you have to actually recover the entire thymus gland as well as the fat. And in this process, even if you make a hole in the opposite pleura, don't be scared, and you don't even need to close that hole, because after you have got rid of the carbon dioxide, you will be able to close it. The space will close automatically.
Okay, thank you. I hope the delegates are able to receive the messages and receive the answers to their questions. The question to Dr. Jignesh Gandhi is, did the esophageal perforation heal spontaneously? And what was the outcome of the patient finally, and how stormy was the post-operative phase?
Yeah. So first of all, in benign esophageal conditions, one has to remember one thing very clearly, that if you decompress the esophagus, keep the distal passage free, the perforations are going to heal. I have a short series also of Borhave syndrome, which is also a benign perforation. Even if they have contamination, once you take care of and drain the pus in that area, you keep the distal passage free. In all our patients of perforation, I usually put in a triple lemon Freca tube now. So the trilumina tube works very well. It decompresses the stomach, it feeds the patient to the nasojejunal, and you give a good wash and you come out. These perforations heal very, very well. Very often, it happens that, sometimes we have to go in and we find that area. But let me tell you with experience that you try to take sutures there, they don't heal. Coming to this particular patient, yes, after we drained out, obviously, as I told you, that it is very difficult to find that pinhole or that small perforation. It is like finding a diamond in a pool of mud. It's practically impossible. So you drain out that area well. She was in the hospital for about a week's time. But yes, for her to start her normal deglutition process without the NGF tube, it took us around 3 weeks' time. So we had to wait for 3 weeks. After that, I did a chondrogram, ascertained that there was no leak. That area had completely dried up in the mediastinum, and then she was started on orally. So usually it takes anywhere between 3 weeks to 6 weeks. In Borhave, my experience has been about 6 to 8 weeks that they take to decompress and dry out that area, and that's how it works well. Thank you.
Dr. We have, in addition to whatever Dr. Jignesh has very kindly clarified, we have used fibrin glue right on top just to put it at the end. That's for small perforation. We have done that. There's one thing I was warned, the people who are attending. You see, the suturing is not as easy as in laparoscopy, because you got your instruments between two ribs on either side. So you can see the hole. Sometimes you may have to even replace your trocars. So it's not as simple as it looks. So if it's small, probably just some sort of a washout and some spray should be done. But the bigger ones here, you might even have to put, we have also used omental grafts from below. That works sometimes over the stitching.
In fact, just to add on that, Dr. John, I had to practice vertical suturing and doing the loops when I was working and doing my thoracoscopic. Because in abdomen, you can do the horizontal suturing, which we are all used to.
Absolutely.
While in thoracic, you have to do the vertical way, which some of the Japanese people mention about it. So that works very well.
Sure.
Yeah. So now the next question, it is for Dr. Arun Prasad. Where to insert the ICG for lymphatic leak? No, sorry, it is for Dr. Shilpa Gandhi. Where to insert the ICG for lymphatic leak, and how much time before the surgery or during the surgery? Shilpa, are you there?
Yes, ma'am, I'm there.
Got
So
the question?
Yes, I got the question. So ICG can be done. It can be done diagnostic or therapeutic both. If it is easily available, it should be ideally given on the medial side or the medial foot, just against the first metatarsal in any small vein. It is not very easy to do. Again, I said, these kind of procedures, they need a very experienced IR team also, because finding that small vein and then, installing the dye, it's not very easy to do. Hence, many people, they just do it as a diagnostically to just delineate the anatomy in the form of a CT lymphangiogram. I would definitely, therefore, there's a reason why I did not actually stress on it even on my talk. So the best, most easy way of thoracic duct delineation is to give a high dose of at least 500 ml of cream through the Ryle's tube, just 15 to 20 minutes prior to the surgery, and you would be able to see the leak after that when you're on table. That's it.
Okay, thank you very much. So we are moving to the panel discussion now. So this is, am I able to share my slides?
No.
Are you able to see?
No.
Okay. Now?
Nope.
Okay.
But we can see you well.
Yeah, I know. Yeah. Now?
No.
Are you able to see that?
No. The green button at the bottom, maybe. Yeah, something is happening.
Yeah.
Yeah, your screen is on.
Okay. But it is off at my end. It's okay. I will see from the other end. Again, greetings from IAGES and all the panelists towards the audience. Thank you very much, Dr. Raman Goyal, Dr. Satya Sayanda, and Dr. Ishwar Murthy for being a big part and very big encouragement to carry on with this first ever thoracoscopic program in the IAGES mentorship. I just wanted to say a few words because there were so many questions which talked about the how the thoracoscopic came in and what are the different indications. So I thought maybe I would put in some 2-3 slides about it. You can see here the first slide where thoracoscopy came as endoscopy of the interior of the chest way back in 1910 with the cystoscopes like all the rest of the laparoscopes. In subsequent decades, the technique improved with 2 things. One, most important for thoracoscopy is introduction of separate lung ventilation, which could happen from the 1960s onwards. So allowing the procedures on a non-ventilated lung. And the second, of course, the video camera and the instrumentation, which could make us make it very feasible, the VATS and the total thoracoscopic surgeries also. As far as the indications of the VATS are concerned, this is from 1992 till 2002. It was restricted to diagnostics, that is fluoroscopy, mediastinoscopy, lung biopsies, pleural biopsies, mediastinal biopsies. Small thoracic procedures like the sympathectomy. Sorry, we missed that lecture today because Dr. Biswas could not join. But in the next program, which is going to be A to Z about thoracoscopic surgery, which IAGES is planning in the month of November. We will have little more time and more extensive talks about the whole thoracoscopy gamut. So small thoracoscopic procedures used to be sympathectomies, surgeries for pneumothorax, and splanchnicectomies. After 2003, many things could come in as the large thoracoscopic procedures, including lobectomies, thymectomies, esophagectomies, the pneumonectomies, and many more. Now we are moving to the complications of thoracoscopic surgery, trouble prevention and trouble management. Are you all able to see the slides now?
We can't see your slides.
You can ask your question. Forget the slides. You can ask your question.
Okay. So the complications of thoracoscopic surgery are, first of all, it is not very frequent, estimated to be 3 to 4% in an experienced hand. Most frequent complication being the prolonged post-operative leak, bleeding, infections, the post-operative pain, and recurrence at the port side, not to forget the organ injuries. And many complications can be avoided by ensuring better selection of patient, better preparation of the patient, and the proper operative technique, including the positions.
Can you say something? Yeah, sorry. You see, the indication should be the same as an open surgery. It's not thoracoscopy. Is like we have been doing thoracoscopy since 1992. 93, we did a esophageal mobilization. So the perforation rate is probably going to be the same, but lung complications are definitely less and the pain factor is less. Regarding the position, one more word I just wanted to say. We started with lateral position. We went on to prone, then went back to 3/4 prone position. But sometimes when the post-op there is a problem, you want to check whether esophagus is patent or not. Despite all the CT scans, you may still have to do a thoracoscopy, especially if you're doing a repeat thoracoscopy or a possible leak that doesn't subside. And if you want to know the location, sometimes you may have to go in with a thoracoscope. So remember, while positioning the patient, you should be able to put the scope in. And if you can't, put the scope in gently before. Sometimes even a bronchoscope, because smaller. Gently put it in before you position the patient. That's something I thought I should mention.
Oh, that is very true. The classification of surgical complications of thoracoscopy is done by Clevian and Dindo, where they classify it as per the grades. Grade 1 being non-life threatening, not requiring any use of drugs, treated only with bedside interventions, do not lengthen the hospital stay longer than twice the median. Grade 2 will be the potentially life-threatening, requiring only drug therapy, total parenteral nutrition, or transfusions. So maybe grade 1 and grade 2 are the ones where we should be vigilant in catching it up at the right time so that we can intervene at the right time. Grade 3 is life-threatening, requiring therapeutic imaging or endoscopic procedure or re-exploration. Grade 4 is classified as the complication with residual or lasting disability or objective signs of the life-threatening disease. Grade 5 being the death. So I understand that everybody here is been doing a lot of thoracoscopic surgeries of all the spans, all the grades of patients. So I would like to understand from the panelists just one example of what kind of bad complication they came across, maybe what they can recall quickly, and how did they handle. We start with maybe Dr. Sabita. Are you there?
Yeah, I'm here.
Yeah.
So anastomotic leak, where most of your circumference of the anastomosis gives away, you will definitely need to do a disconnection. So endoscopy is essential first to rule out stomach tube necrosis and also to see how much of the circumference has given away. So if your mediastinal leak, your collection is not getting controlled with radiology guided pigtails, then definitely do an endoscopy early.
Okay. Dr. Anjali?
Well, I can remember one azygous vein. If you're using the wrong instrumentation sometimes, which is a little more sharp, and you're trying to go behind the azygous vein, and your angle of the dissection is not correct, you tend to cause friction and you can have an azygous vein injury. Luckily, we could clip it, but clips do come off in the chest. So it takes some time, sometimes some complications can be bad. Yeah, that's one I can remember offhand.
So maybe you will recommend all the locking clips in the thorax?
I will, but then when you have a complication and you don't have some things available at that exact moment and you've used a metal clip, it takes time for the locking clip to come in.
Yes. No, but I mean to start with.
Yeah. Yes.
Thank you very much. Dr. Jignesh?
I remember a case of Borave syndrome that we had drained it primarily, but at that time we could not see the perforation edges very clearly. On the second instance, he got a collection again, and then when I had to go in for the second time, I can tell you, going second time in a condition like this where you have already passed first, the granulation tissue was just bleeding like hell. So in open, it is very easy. You use a hydrogen peroxide pack and just put it in that area. But here, actually, I had to use a combination of a spray coagulation, and I had to use Tisil in that area finally to just spray in that area, and then there was a good hemostasis. So I think bleeding is one thing which in thoracoscopy, because of the limitations of putting things inside, it's a little bit tricky. So one has to be ready with the sealant agents and hemostatic agents, understand, because these are the low volume, low pressure bleeding. I always talk about that the surgeon is always worried about low volume, low pressure bleeding, because there is no solution to that. And it just keeps on irritating, and it comes at the last part of the surgery whenever it comes in. So even if you take a stitch, you are worried it's a raw area. So use of sealants should be in the armamentarium of the surgeons when they are doing thoracoscopic work. Thanks.
Yes, thank you very much. Dr. Shilpa? You're on the mute, my dear.
Oh, I'm sorry. Oh, sorry. What is the question? I just lost the sync of this.
No, we just wanted to understand the very bad complication which you have come across, and maybe what do you think should be the preventive measures? As a take-home message. You can think about it. Maybe I'll go to Arun Prasad first. You can think about it and get back to us. Okay.
But I've come across the most dreaded complication is during a lobectomy, and that is very recently, in fact, here we have come across, and that is the injury to any of the pulmonary artery branches. I mean, it's the most dreaded, and we have very recently come across to it. But if you are not good in suturing techniques by VATS, then it is very difficult to handle these kind of complications. You have to straightforward convert it. Otherwise, you can that's the only fallacy of VATS actually, and progression from basic VATS surgeon to an advanced VATS surgeon. You should always be very good in your hand suturing techniques so that you can deal with these dreaded complications. Otherwise, you would land up in converting it into a thoracotomy and then actually suturing it with the 4-0 proline sutures. And we have recently come across this patient just 2 weeks ago.
Yeah, we understand that bleeding in thorax can be one of the very hilarious complications. And what is difference between the laparoscopy and thoracoscopy is, even though the rigid wall helps us in terms of creating the pressure and staying on with without any collapse of the pneumothorax, still it is very difficult when it comes to any emergency handling and typically the suturing, because in various positions there is no elastic wall which can help you in terms of movement. Yes, you have to know the thoracic anatomy first, before in hand. You should have a backup of open thoracoscopic surgery anytime you wish to go ahead. And of course, you should read the radiologically the images first. in a proper way so that you don't land up into troublesome situations. That's very true. Dr. Arun Prasad, will you be able to share some few, one of the cases which you remember as the, tough things as complication? Are you there, Arun? So, Amol. Dr. Amol?
Yeah. So, two cases I remember. One was a VATS left upper lobectomy, one of my first few cases at Hinduja. We started somewhere in the evening and were almost about to finish the case by about 9 p.m. And I had finished the entire hilar dissection, and it was for an aspergilloma. So there were dense adhesions at the apex. But in VATS, usually there is one tip to keep the apical adhesions in place, finish off the fissural and hilar dissection, and then go to the apex at the end, because it helps to keep the lobe retracted with those adhesions. So towards the end, I was dealing with these apical adhesions, pretty dense ones, and my camera was in the inferior port. So probably just the last bit was left, but that adhesion was to the densely adherent to the subclavian artery, and I tried to divide it with a harmonic, not shifting my telescope to the anterior port to get better vision, which I realized I should have done later on, and I ended up injuring the subclavian artery. So we had to, the patient almost crashed, and I had to quickly convert, but luckily we managed to save the patient, clamp the vessel, and to my fortune, a vascular surgeon was just finishing a case in the next theater, so he came in to help me, and then we could repair the subclavian artery. So that is one complication I remember. And second one was it was a left upper lobectomy, again for an aspergilloma. This was actually a live surgery going out from my own theater, and there after putting the vascular stapler onto the superior pulmonary vein, it got fired, but while removing it, the vessel got avulsed, and there again we had a tough time opening and then controlling that bleeding. So these are two complications which I distinctly remember.
Yeah, I think Dr. John, you can tell us about whether tumors are better than the infections to be treated thoracoscopically.
Sorry, say that again.
Maybe you can tell us about, in the beginners, whether infections are better to be treated thoracoscopically or the tumors.
Well, I think both can be, but depends. For instance, if we take an empyema, acute empyema does not require any thoracoscopy. Probably needs some aspiration. And the timing is so important. If you leave it after 3 weeks, become chronic empyema. No thoracoscopic surgeon is going to take it out because chest won't expand. It needs complete tearing, which is most probably impossible through the laparoscope. And so the ultimate result is to see whether the chest opens. I mean, these are all things we discovered. Nobody taught us. And the other thing is about tumors. Again, if you're going to operate on C esophagus, I mean, I'm basically from Vellore, trained by Adelaide, Australia, Professor Glemison and all these people. You see, the thing is, they are guys who treated C esophagus, especially squamous cell, with chemoradio, and the whole thing subsides. They have an endoscopy. So that sort of a patient was endoscopy, CT scan, PET scan. There's nothing there, no need to do anything at all. No need for surgery. But if there is any residual tumor, any evidence of a tumor, if you're going to do open surgery, thoracoscopy, if you're good, your team is good, it's useful. But sometimes if you send it to the wrong people and they fry the esophagus, life is hell. So it depends on the team, depends on where you're working, and also the stage of the disease where it requires surgery. It needs a very mature decision. And very often it's multiple people have to take part in the decision. It's not that you're a top cat and you can, you're a very highly trained pilot, you can go into any mission. You got to gauge the whole thing. If you're basically, I think one must be a good doctor and a good surgeon to take a very considered decision with your colleagues. Only then you should go in. And even then discuss all the complications and tell the patient. For instance, our first esophagus was 1993. And initially, we told the patient, we have never done one before. We have only read the description of Pucciari. So when we started doing, our recurrent lesion, especially on the left side, was slightly there. Though thoracoscopically, we have started clearing because the scopes are quite not very good those days. We had single chip, but then digital camera, digital imaging was very good at that time, was considered good. But later on, I realized my dissection while doing the cervical esophagus with my finger was the one that damaged the nerve, not my thoracoscopy. I mean, it's a stupid complication thinking about it. So these are all things by which we learned. Sometimes the other member of the team is very important. I don't usually operate neurosurgeons, but I think once we got the neurosurgeon to come in, he's a very good friend of mine, my wife's classmate. So, he saw me doing the whole thing. We were doing decortication and there were more than 3 ribs and 3 vertebrae involved. So he said he's going to put a thing and screw. So somewhere he said, John, I will take over. And he took the forceps and I said, be careful. And he jammed it into the intercostal artery. The bleeding waves were torrential. My first assistant just held on to the artery and then used the suction. The lung kept falling in, blah, blah, blah. But the assistant caught the artery in time. So that's why the team is very important as well. It's just not the surgeon alone. Maybe a nurse, maybe even a car driver. But the team is very important, depending on how much you've trained others. All this has to be considered. We're looking at infections and malignancy.
Yeah. So I would like to direct this question to Dr. Bhushan Thombre also. What will be your advice as a beginner? Which kind of thoracoscopic operations people can opt for?
Yes. First of all, I would say you should have observed ample of surgeries as an assistant to a thoracic surgeon nearby, certified thoracic surgeon nearby, or the best method is you have to get yourself enrolled into some training program. If at all that is not possible, you're too old to undergo training, you can undergo somewhere observership where high volume thoracic surgery, wide variety of work is done. And after that, then you can contemplate some diagnostic thoracoscopics like for pleural effusions, malignant pleural effusions, pleural biopsies, and then eventually going on for pneumothoraxes, where the patients are very carefully selected, where you should not have any mishap or any complication for first 100 or to 200 cases. That will gain your patient database confidence and even general public acceptability, where you find that you're not capable of doing any heroic work or any much advanced work, then you can definitely refer to your nearby expert thoracic surgeon. That is the in general advice I would like to give for the beginners who would like to start thoracoscopy.
So my next question is directed to Dr. Khan.
Yeah,
are you
hi.
there, Dr. Khan?
Yeah, I'm here. I've just logged in. Thank you.
So one question: is there any indication for emergency thoracoscopic surgery?
Yeah, absolutely. There is every indication for emergency thoracoscopic surgery. The bottom line is, I understand your question is indications of VATS in trauma. That's the question you asked, I'm assuming. So yes, we do do VATS in trauma, but the first and foremost is that the patient should be stable. ABCDE has to be followed. You cannot try to save. You cannot try to do VATS and lose a patient. So you must follow the ABCDE principles. Stabilize the patient to make sure he's hemodynamically stable. Get him into theater. Pneumothorax usually I actually manage by VATS. Most of the pneumothorax I would go in by VATS, try to suck out the blood and look at whatever is the source of bleeding. We have managed bleedings from intercostal arteries, bleeding from IMA, bleeding from pulmonary arteries. But of course, you need a bit of experience to do that. In a trauma situation, if you're not experienced, then you should not be putting in cameras into the chest. An open thoracotomy will save a patient's life. But if you're experienced, and now we almost invariably always start any surgery with a camera in the chest. And you'll be surprised how well you can take everything down. And you can suck the blood out. Vision is the main thing. So we've also done VATS, traumatic injury to bronchus, right main bronchus. That's traumatic injury to the trachea, where you just go in and put a couple of stitches around. But the patient has to be stable. If the patient is not stable, just do an open surgery, because you need a live patient at the end of the thing. It's not about VATS. It's about getting a live patient at the other end.
What we have found is, in our practice, penetrating injuries of the neck, of the abdomen, and of the thorax, all three places, diagnostic thoracoscopy has helped us go ahead with the right decision making in terms of which area needs exploration. I think some of the things that is one of the situations where I say that all general surgeons should be well acquainted with the minimum diagnostic thoracoscopies, because that is something which can save a lot at the patient's end if done at the right point of time. Now we move to the next level of thing, that is about bleeding. Bleeding is something which can come to any surgeon in a very particular way in terms of control, which can be a little tough. Maybe few things are already discussed about bleeding, so I want to like to go ahead with a lot of discussion about bleeding. Many surgeons have already talked about it. I will go ahead with the prolonged air leak. So this is one thing which can create a lot of nuisance in the post-operative phase of any thoracoscopic surgeon's life. So Dr. Bhanushali, would you like to talk about it? You have covered a few things, so I said it's a good idea that you talk about it.
Madam, I'm sorry, could you please repeat the question?
Can you be louder, Amol?
Can you hear me?
Now better.
Yeah, so I'm sorry, could you please repeat the question?
See, prolonged air leak is something which can create a lot of nuisance in the post-operative phase of any thoracoscopic surgeon. So what is the definition of prolonged air leak? How should be the approach? Are there any grades? Can you please talk about it?
So yeah, prolonged air leak is a nagging thing for every thoracic surgeon, especially if you have to send the patient home with a tube. You are not very happy with doing that, and every surgeon wants every patient to go home with the tube removed before discharge. But at times you do experience prolonged air leak in few procedures, especially things like decortications for chronic empyemas. So there, as I mentioned during my talk, during the procedure, make sure that significant air leaks are managed then and there by suturing or by whatever techniques you want to. Make sure the lung is fully expanded. If the lung doesn't expand completely and stick to the chest wall, if there is a space left behind, then these air leaks tend to keep continuing. So, in short, the decortication has to be thorough enough for the lung to fully expand and stick to the chest wall. Then the chance of having a prolonged air leak is lesser. If you still have it, usually most of them are going to stop by keeping the tube for a slightly longer time. So the tube can be connected to something called as a flutter bag or a Heimlich valve. Heimlich valve is not so very commonly available. So you can just connect it to a urine bag with a non-return valve. I in fact learned this from Dr. Khan himself, that you can use this a simple urine connect it to the tube, and you can send the patient home with that. And usually these leaks tend to stop within a week or so, week or two, and then once the lung is well expanded on the subsequent X-ray, and there is no fluffing of the bag, later on you can remove the tube. Another trick is to use negative suction at the end of your procedure. So connect the ICD tube to negative suction right at the end of the procedure. The maximum pressure you can use is minus 20 centimeters of H2O, and I have been doing that since the last about 3 to 4 years, especially since I procured the Medila digital negative suction device. So I've been using that for almost each and every procedure. It helps to keep the lung expanded, helps to keep the lung stick back to the removed parietal pleura, or if you done a pleurodesis, whatever. It helps to keep the lung expanded and helps to reduce and get away with the leak faster. So these are a couple of tips that I can share.
Okay, nice. Thank you very much for sharing this. I think next time we should have one good session on prolonged air leak, because it's a very, very important thing to talk about. Infections, as we all know, that it can accompany any of the surgeries, and typically I won't go into a lot of details because here the management remains the same like any other infections. Only thing is you have to be careful about the collapsing lung and developing empymas. So I think that can be a very worrisome situation, but this is a very preventable thing. As Dr. Amol said, the expanded lung is the answer for many questions as far as the thorax is concerned. The next complication which we find is post-operative pain. And
can I just raise a question about your previous slide?
Yes.
You're saying that the prophylactic use of antibiotics is controversial. Actually, antibiotic prophylaxis is highly recommended and highly well studied within the thoracic surgery area. But we're not talking about use of antibiotics over a prolonged period of time. We're talking about either a single dose antibiotic at the time of induction or a 3 doses of antibiotics. Cefuroxime 750 milligrams, half an hour before incision. And if the surgery is more than 3 hours, then give a second dose. And if you're worried about, blood loss and things, you give a third dose post-operatively at 8 hours. And that is very, very well studied and very well documented. It is actually not controversial. When you say prophylactic use, you mean to use antibiotics at random? That is not allowed. But a prophylactic antibiotic prophylaxis is very much part of VATS.
Okay. Thank you very much for sharing this. And next time it will be changed in the slide. Post-operative pain. People do come across do opt for minimally invasive surgeries for typically the pain reduction. Pain becomes a very big part of the story when somebody is there in pain and not liking it. It is a statistically significant thing when a patient's dissatisfaction index is concerned. So maybe Anjali, can you tell us about post-operative pain? What kind of some 3 or 4 points which you would like to take care in these patients? As one thing is the intercostal nerve injury. Of course, everybody has talked about it, how to avoid the injury. What are the other things you would like to talk about? Or maybe any of the panelists who want to share about it. I understand Anjali was not well for some time. Anjali is a COVID warrior and she is recovering out of that. So take it cool, Anjali. Anybody who can share about post-operative pain, most welcome, including yourself.
Yeah, post-operative pain, usually it starts with the crimes done in the theater while operating. So that's the most important way of reducing your post-operative pain, is by being careful about how you handle your instruments and how you go into the chest to avoid the post-operative pain. Of course, some people are more sensitive to post-operative pains. Local infiltration is extremely important, and also having a good anesthetist who will be able to manage your post-operative pain either using some kind of blocks or using some kind of pain suppression medications. So I don't know, apart from that, whether anything specific for the thorax. No.
Yeah, well, we have a protocol for pain management. Number one is that you have to intraoperatively make sure you don't use hard, what do you call it? I've forgotten the word now. Hard ports. In fact, in thoracic surgery, you should not use any ports. Wherever your instruments are going in and out, you should not use ports. You must use just a wound retractor or wound protector so that your instruments go in and out pretty well, or put in stitches to leave the wound open. The use of we have studied the use of preemptive analgesia, and we found that actually definitely reduces pain. Early use of transdermal patches has been recommended. In my unit, we use buprenorphine or fentanyl patch and very quickly get rid of the pain. You have to break the chronic pain cycle. And we've also studied the use of long-term. If the patient goes into pain 4 to 6 weeks after the surgery, when the wound has healed, then we use yoga and local Ayurvedic oil medications over the wound. And that actually, we have published that data showing that reduces post-operative pain. You must treat the VATS wound as a thoracotomy wound. Whether you like it or not, you must give it the same respect. And you must make sure that the intercostal neurovascular bundle is not compromised. That's the key thing.
Yeah, thank you very much. Maybe Dr. Sabita would be able to add a few things about the protocol for post-operative pain. You people are doing a lot of major surgeries in Tata Hospital. And what is your any particular pain protocol, if you can share? You're muted.
Sorry. So typically for esophageal thoracoscopic surgeries, we would still use an epidural, but not for mediastinal and lung resections, because lung resections we are mostly doing uniportal now. So we infiltrate the port site. We also, our anesthetists also give paravertebral blocks. And in the postoperative period, if you notice, it is the ICD which gives more intercostal drainage tube, which gives more pain to the patient than the incision itself. So you have to have an aggressive ERAS protocol in place where you start mobilization, chest physiotherapy, and get rid of the tubes. Once you get rid of the tubes, the incision for a VATS usually does not give that much pain. So use as small tubes as you can and get rid of them early.
Okay, nice. The recurrence at the port site is one thing, which is one of the connected complications as far as the technique is concerned. The risk of this complication may rise in treatment of some particular things like the metastasis or the malignant pleural effusions, something like this. Special aggressiveness, it needs to be done in those particular conditions. So typically, I wanted to understand from Dr. Sabita, is there anything in particular you try to apply, or maybe Shilpa you can add here, if you want to apply a few things to avoid the recurrence at the port site?
So the first thing is that always use a bag. However small your specimen is, even if you think it will slip out of your wound protector, even if you're using a wound protector, always use a bag to retrieve an oncological specimen. Sometimes you may do a procedure, take a wedge of the lung, thinking it's a benign thing, and the final histopathology may be different. So always use a bag. And also in cases like you mentioned in your slide, mesothelioma. So mesothelioma, typically the port site metastases are the sites which are used for intercostal drainage. So you should remember not to put ICDs in a mesothelioma. If there is a pleural effusion with a thickened pleura, drain it, then try and do a ultrasound or a CT guided biopsy, or you can also do a thoracoscopic biopsy, but you have to be very, very careful in the case of mesothelioma. So VATS, we have been using bags like for the last 10-15 years, and we have not seen any port site metastasis.
Okay. Maybe Shilpa, I would like to give you some other complication, or maybe you can say question mark when a surgeon is operating. I'm not going into a lot of details about the typical lung biopsy, wedge resection, bleeding, air leak infections, because this is covered. Anatomical resection of the lung also, we have covered many of the things in the common complications. But this is something which can be one of the difficult things, difficulty finding a tumor or the pathology. You are in the thorax and you are unable to find it. What should be the strategies to avoid it, or on table, how should you deal with it? First, Dr. Shilpa and then Dr. John Thanakumar, if you can add to the, these are last 2-3 questions only.
Yes, rightly said, difficulty in finding a tumor while you are doing a VATS surgery. So you can avoid this by doing a pre-operative localization by detailed, starting right from the basics, detailed reading and correlating the radiological findings. Secondly, you can do a needle localization just prior to taking the patient on table. So you could do it CT guided, or there are needles, radioscopic needles, which are available in certain interventional in IR teams. So you can use that. Thirdly, when on table, in very advanced centers, I'm not very sure that it is practiced in India, but in very advanced centers, yes, ICG dye, again, it has been very helpful in localizing these tumors. But there is a way, there is a software, you need to actually, subtract it and find out the exact segment or the lobe where the tiny SPN is located. Thirdly, on table, if it's a surprise, it shouldn't be a situation which would be very alarming, because you've made a utility port incision, it's at least 3 to 4 centimeters long. You can actually put in your index finger inside and palpate the entire lobe and try to correlate it with the radiological finding. And you should be able to, at least, even if it's a tiny tumor, there could be a scarring, or you will actually, it's a palpatory technique. You will be able to find a difference between a normal lung parenchyma and the suspicious segment or the lobe. So these are the various methods of finding the small or tiny lesions in the lung when you are doing a VATS or a wedge biopsy.
So I think whenever we are doing any thoracoscopic procedure, like the laparoscopy, we have to take SOS open consent for the on table in case needed, right?
Yes.
Now maybe yes, please.
Yeah, nothing. This is actually one of the indications of converting a patient from VATS to open. Even if it is a small GGO, there are surgeons who are, when they are not satisfied in, even with a intraoperative palpation of the tiny GGO, they have converted it successfully and done a segmentectomy or a lobectomy, even for a very tiny GGO of say 8 mm. So this is a very direct indication for conversion to open.
That is,
would like to
nice
add
to
it. If at all you are intraop, if you are unable to get the tumor, you can extend the same incision, make the lung available to your finger. That is what. Free the inferior pulmonary ligament, release all the adhesions, make the lung available to your finger, do the proper finger palpation. If still not getting, you can make another port. Don't hesitate to make another port in the backside, where you can feel the tumor. If still not, then you can do a open procedure. When all other methods fail, then ultimate is the diagnosis. Get a frozen section done. Confirm that you have taken the right node.
Can I just add to that? Sometimes you can ask anesthetists to bag the patient or collapse lung. If you have bilumen tube, bilumen tube, it's fantastic because they can collapse it just outside the exit wall where it comes out, and open the thing completely and put in a suction, make sure it's completely evacuated, you can see. Because initially for the new thoracoscopic surgeon, everything will look like a nodule on the lung, on a collapsed lung. So this way it will be completely empty. And then you can feel it. Very often it would collapse, make them blow it, feel it. And as has been rightly said, add a port. If you're still not sure, make a localized conversion. I wouldn't do a normal conversion, make a localized conversion, see whether you can get it. Get a frozen organized, all that is.
Yes. Thank you very much. That was really a good insight.
I have one personal experience to share with.
Please go ahead.
Yeah, one time we had a nodule. Yeah, which was very difficult to palpate. We lost our local.
Hello? Hello?
Can't hear.
We can't hear. Can you hear me? Hello? Hello? Are you able to hear me?
We can hear you, madam.
We can hear you, but not him.
But not him. Exactly.
Okay. So I think maybe once he can talk, we will listen to him. There are a few more things which I am not going to discuss because every speaker has included this in their topics and it is already been touched upon. Upon the sympathectomy and the splanchnistomy, the things are not discussed, but I think these are the common complications. Apart from the common bleeding and pneumothorax complications, we are able to see here the Horner's syndrome needs to be dealt with in a very, very particular way. But I won't be covering it. Maybe one of the speakers can talk about it. I don't have much experience about this Horner's syndrome. Can somebody tell us about just few lines?
I think Horner's syndrome consists of 5 things, as we know. I don't know how to treat it. Once you get it, you had it. You tell reassure the patient, wait for it to go away, and probably would refer it to neurologist. But anhidrosis, and partial enophthalmos, meiosis, and what else?
A lot of sweating is there, yeah.
Pressia normally dilates, it won't dilate. And the last 5th point, I forget.
So I think it's a good vigilance, good observation of the post-operative patient is very important in this. We won't be discussing much about it. Even for the esophagus, we are not going to discuss many things. I would like to say thanks a lot to all my faculty, to IAGES, Dr. Raman Goyal, Dr. Ishwar Murthy, and Dr. Sayanda, who have been instrumental in creating this first ever program in the thoracoscopic surgery, like the ABC and the masterclass. I have been behind the IAGES team since more than a year now for this, and I find myself lucky to get introduced with this topic to the IAGES audience. Over to Dr. Ishwar Murthy now.
Thank you, Jaya. Can you see my slides?
Yes.
Just last, I'll take. It's really wonderful. I have the pleasant duty of giving vote of thanks for all the faculties. I think this is the 5th and final IAGES masterclass by the IAGES Academic Council today for thoracoscopic surgery for general surgeons. I think, Jaya, I need to thank you. You put all the 5 important concepts, laying the foundation, getting the basics right, thoracoscopy for the lung, non-lung, and trying to bring all the 15 faculties on board, trying to discuss all the complications. I think I need to set greetings from our president, Dr. Raman Goyal, and all the Galaxy VC. In particular, we have right now with you our chief advisor, Dr. John Tanakumar, one of the senior most thoracoscopic surgeon in India. And thank you all the faculties. I think you would have seen your feedbacks, but the feedbacks I received to IAGES website, it's awesome lectures, simply super, great selection of faculty, wow, treasure to save and share. So these are all the feedbacks. So I'm sure we should thank you all. Jayashri, it is only for, not only for you a certificate of appreciation already knocking your door, but everybody would be receiving one in their phone already. Thank you all. And people who not able to see the last few parts, they can go for IAGES Connect, because we have IAGES YouTube channel, Facebook page, Twitter, and also www.iags.in. You can see all the 5 masterclass videos are waiting for you to see again and again, anytime. And we have to salute our warriors, both at the borders and also all of us trying to do day and night, fight the COVID pandemic. And not to forget Docplexus, Kritika, Nishkumar, all the people, because we are going to be with them next week, 9 p.m. with IAGES prime time, one of the memorable occasion we are going to have with Professor Wadia, a father of laparoscopy in India, our founder president, speaking to Alfred Kusheri for 1 hour. So it will be a very, very memorable occasion. Please, all of you, all the delegates, please join. And the subsequent month in October also, pin in your calendar, 15th and 16th, we are having Indo-UK Surgicon. So until then, thank you, Jayashree. Thank you, faculty. Thank you, Docplexus. Bye-bye. Goodbye from IAGES office.